Another edition of the Clinical Neurology Forum. And in today's forum, it is the Department of Neurology from JIPMER, Puducherry, who will be presenting cases under the leadership of Professor Vaibhav and Dr. Ramkumar, who will also be a moderator. And this session will be chaired by Professor Sundar, Professor and Head of the Department of Sri Ramchandra Medical College. So I hand over to Professor Sundar to conduct the proceedings. Professor Sundar, please.
Thank you, sir. Thank you for the opportunity. So let us go straight to the case. I request the presenter to present.
Thank you. Good morning, one and all present here. So first, I would like to thank the Department of Neurology, JIPMER, for allowing me to present, and also the Clinical Neurology Forum for allowing me to present in this forum.
Welcome, Dr. Pushkar Paini.
Thank you, sir.
And to introduce him to others, he is the illustrious son of their great father, illustrious Dr. Professor Paini. You can go ahead.
So before we go into the case details, just a short note about the demographic details of the patient. So our patient was a 55-year-old male who was coming from Tirukottaram town, which is near Karaikal district, and he was employed as an office assistant in the government taluk office. And because of the patient's confusion, and he was not in a position to give the history at the time of the index admission, so the history was obtained from his wife, who is currently staying with him along with his one and only son. And his wife has formal education up to 10th standard, and was able to give us a reasonable history regarding the same. So coming to the patient's chief complaints, he had presented to us with a 1-year history of abnormal movements involving the right upper limb and lower limb, slowness of movements involving the right upper and lower limb for the past 1 year, loss of weight as well as loss of appetite for 6 months, behavioral disturbance for 2 months, and difficulty in passing stools as well as difficulty in passing urine for a period of 2 months. So first, regarding the first complaint, these abnormal movements were first noted in the right lower limb. And these are in the form of tremors, which is initially started in the right lower limb, which was first noted by his friends in his taluk office. Who actually used to make fun of him, and I kept on asking him why he used to shake his leg during times of lunch. But however, these movements were there only when the patient was ideally sitting or ideally lying down. It was not present when he was walking or changing the gears in his two-wheeler. These were noted by his wife to be coarse.
Just a minute. Paini sir, please mute everybody except the speaker. Please mute everybody except speaker. Okay, Pushkar, go ahead.
Okay, sir. So these tremors were in the right lower limb, initially noted by his friends at work, and they used to casually make fun of him because of this, and they used to keep asking him, why is your leg shaking like this? But however, this is the first time the patient had noticed it. Before that, he had not mentioned it to his wife. It is more prominent when he's idle, either when he's sitting down or lying down having a nap, and it is noticed to be coarse, not voluntarily suppressible, and predominantly present in his feet, that it is distal predominant. It's not noticed when he is walking, when he is changing the gears in his two-wheeler, and his wife mentions that this abnormal movement is absent during sleep. It is not associated with any tightness of limbs or any other involuntary movements, and it is also associated with slowness while walking, which I will elaborate later. And around the past 6 months, the patient has noticed a similar abnormal movement in his right upper limb, and this similarly was more when he was more at times of rest or when he was keeping idle. It was coarse. Yet again, it was not voluntarily suppressible. It is present only in his hands, that it is still predominant. And it was first noticed when he used to make the entry records into the taluk office. So the main work of the patient is actually to send important postals as well as receive important postals to and from the taluk office. And he has to make entries of these in the postal record. So during this point of time, according to his wife, his handwriting used to be very large and very much neat earlier. But after the onset of the symptoms, his handwriting has become less legible and has become actually smaller than usual. And his Tahsildar had also chided him many times because of this, saying that his handwriting is not legible when they go through the records. And also he spills tea glass contents when holding it for a prolonged period of time. But however, there is no associated smearage of food, and there are associated slowness of movements in the right upper limb, which I will elaborate later. And there is no other history of any other abnormal movements other than these. And there were no associated recurrent falls. There was no history suggestive of any postural instability, and no history of any giddiness when the patient is getting up from the sitting position. Now coming to the slowness of movements, and yet again, this has been there for the past 1 year and has occurred along with the involuntary movements in the right lower limb. The patient is very slow to walk. This was first noticed by his wife, who used to keep complaining that he was very slow and could not keep up with her speed while walking. And but however, he had not noticed this complaint till his wife had mentioned this. And he was also very slow to change his gears in his geared two vehicle using his feet. And sometimes many times his vehicle had actually stalled because he could not change the gear fast enough along with pressing the clutch. And he is also very slow to sit as well as stand. And these complaints have been slowly progressing over the past 1 year. And for the past 2 months, the patient has been bedbound and needs the support of 2 people to ambulate even to the restroom. There is no complaints of stiffness of the limbs, but of course, the patient was very much confused at this point of time. And there was no history of any recurrent falls or postural instability. And these similar symptoms had also involved the right upper limb, almost a similar time when it occurred in the right lower limb. And it was first noticed when the patient used to take a lot of time to mix his food while eating. And he also used to take a lot of time to even bring the food to his mouth while eating. And normally he used to complete his lunch in his office, in the taluk office, by a period of maximum 15 minutes. But his Tahsildar as well as his co-workers used to complain that he's taking a prolonged period of time during the lunch break, taking sometimes even 40 to 45 minutes to have lunch, even though the designated lunch period is only 30 minutes. And the Tahsildar also had chided him that he puts in the letters into the envelope and posts them very much slower than earlier, and he had got scolded for this because of this. And he's also much slower in entering the records into the postal entry book. And because of this, he has actually not been going to work for the past 3 months. But however, there's no associated stiffness in the upper limbs. And these have been worsening over the months. And currently, he needs to be spoon-fed by his wife for consumption of food. He's not able to eat by himself because of the slowness of movements. So these abnormal movements and slowness of movements have been progressing over the past 1 year. And the new complaint for the past 2 months has been behavioral issues. So these behavioral issues initially started as anger outbursts. And these anger outbursts were either unprovoked or present only even with very petty issues. So he used to pick up a lot of tiffs and easy arguments with his wife. And even though his wife mentions that usually he is very amicable and very polite, and it is very unusual of him to act in the same manner. And he used to keep ruminating about the same thoughts about old things, and used to pick up fights with his wife about issues which had happened around 20 to 25 years ago. And these behavioral issues, which had started as these anger outbursts, over the next 2 months, he started to develop visual hallucinations. So these had initially started when his wife had noticed that he was talking to himself irrelevantly. So on inquiry about the same, he used to say that there was some sort of small child who was sitting in the corner of his room. But however, he did not feel that this visual hallucination was threatening. But however, he used to keep pointing towards the corner of the room, especially towards the night, and used to keep talking to someone. And he also used to keep saying that the Tahsildar in his taluk office is walking around his room, and he used to keep saying his wife to keep quiet because sir is coming and he doesn't like us to talk very loudly. And he used to keep pointing towards the fan and kept on saying that it's going to fall down and we need to keep changing the fan, even though there was nothing of that sort. And he also used to keep telling to his son that his son needs to return 5 lakhs, which he had lent to him earlier. But according to his wife as well as to his son, there was no such transaction which had occurred. So it seems that the patient is having some sort of delusions in the form
Hello. Can you hear me?
Yes,
Yes, sir, it's audible.
Yes, sir, we can hear you, sir.
Okay.
Presentation is on, sir.
Yeah.
So on the background of these visual hallucinations, behavioral issues, and delusions, over the past 2 months and around 10 days before the index admission, the patient had become very confused, somnolent, and was very drowsy, and was confused and occasionally did not even recognize his wife and son at periods of time. But however, this confusion was fluctuant, And along with the somnolence, at some point of times, he had also difficulty in sleeping. Ordinarily, he would sleep at around 9:30 to 10 p.m. But over the past 10 days, he's been sleeping only at around 1 a.m. or 2 a.m. or sometimes at one point of time did not sleep the entire night and was only sleeping in the morning. So after these, for the past 2 months, the patient has also noticed difficulties in passing urine and passing stools. The patient needed a lot of effort while passing urine. And even after so much effort of straining, he had a sense of incomplete evacuation. And while passing, his urinary stream was poor. There was associated dribbling of urine. And at one occasion, he did not pass urine for a period of 24 hours, for which he needed to go to the local hospital and needed to get a urinary catheter. But however, he is able to indicate to the wife that he needs to use the restroom before he got the catheter. And when he had come to us, he was already on a urinary catheter. And on a background of this, the patient has been having significant loss of appetite as well as weight loss for the past 6 months. So this initially started when the patient used to say that he was not hungry and used to start skipping dinner. And over the days, his overall quantity of food has decreased. And currently, when he had come to us, his diet is restricted to semi-solid and liquid diet. And actually, he needed to have a Riles tube to be placed to maintain adequate nutrition. And for the past 3 months, he has had significant weight loss, which is unintentional. And the patient also. I think my voice is echoing, sir. Yeah, okay. His wife also noticed that his shirts and pants had got very loose, and they actually had to buy a smaller sizes in the recent times. And this weight loss is actually initially noticed by his close relatives who had come to meet him. And coming to other associated symptoms, there was no history of any fever, cough, vomiting, no history of any dark stools, hematemesis, no history of any painful or painless swellings over the neck, inguinal region, or any part of the body for that matter. And there was no history of any decreased vision, double vision, difficulty in swallowing, any facial deviation, auditory symptoms, or swallowing difficulties, or any regurgitation of feeds. There was no associated complaints of joint pain or rashes. Coming to the past history, the patient is a known case of systemic hypertension for the past 1 year, which is relatively well under control. His systolic blood pressure is usually around 140 to 150, and he's on 5 milligrams of amlodipine, which he takes in the night. And he also has history of childhood poliomyelitis, for which he has a residual weakness in his left lower limb. But however, despite this, he is able to ambulate and even use his vehicle also. And there is no other medical comorbidities, no history of any previous surgeries. However, around 1 year before the onset of symptoms, the patient has history of native medication intake. So this native medication intake is both in the form of Ayurvedic medication as well as Siddha medication, in the form of powdered formulations as well as oral solutions. And these native medication intake was for a period of 6 months, and it is taken for an intermittent dry cough, which is not associated with any other hemoptysis or any other symptoms. But however, this cough symptom is not currently present, and this native medication intake was 1 year before the onset of symptoms, which is taken intermittently for a period of 6 months. Coming to the personal history, according to the wife, the patient is a non-smoker. He used to consume around 180 ml of alcohol once a week, usually hard liquor in the form of brandy or whiskey. However, he has been abstinent for the past 1 year. On inquiry on the reason for his sudden abstinence, his wife said this because after the onset of these abnormal movements or tremors, he had initially accounted it to his alcohol habit, so he had stopped after that. And there is no history of any other recreational drug abuse or anything else. Sir, shall I proceed with the symptom analysis, sir?
Yeah, sir.
Just a minute. I just have one question. Sundar, can I ask one question, please?
Yes, sir.
Pushkar, was there any breathing difficulty, any history of breathing disturbance?
No, sir, not at all, sir.
Okay. Thank you.
What
Sundar
time?
sir,
Yes, sir.
Sundar sir, now you can ask the questions at this level about the history and all those things. Then
Yes,
DM
sir,
Madri
we'll go.
questions. Yeah.
Okay, sir. We'll go one symptom by one
Yeah.
symptom. The first
So he's
symptom.
analyzing. So he's analyzing one symptom, each symptom one time, and so you can ask the questions at that time. Yes.
Okay. About tremor, where do you want to localize?
Sir, this tremor is predominantly on the right side, sir, both right upper limb and lower limb. It's distal predominant. It's predominantly present at rest. It is coarse, not voluntarily suppressible, and it's associated with slowness of movement, which probably seems to be hypokinesia or bradykinesia at this point of time. And putting all this together, sir, it most likely seems to be because of extrapyramidal involvement, sir.
Extrapyramidal, now what do you mean by that? Breast tremor is due to involvement of which structure in the extrapyramidal system?
So the left basal ganglia and its connection, sir.
No, for example, there's tremor, there is a pathway, no? Tremorogenic loop is there. So, among the basal ganglia structure, rest tremor is, for example, hypokinesia is due to direct pathway involvement. Okay. Likewise, tremor. Can you tell anything about tremor localization?
So the subthalamic nucleus also plays a role in tremor, sir.
Okay, there are two things are there. One is cerebrothalamic involvement. One is this basal ganglia involvement. Basal ganglia stratum. Stratum is more involved for this rest tremor. It will initiate and is maintained by cerebrothalamic. So this VAM, if you put DBS in VAM, tremor is decreased. No, so the basic mechanism of tremor is due to that pathway. Okay, so the involvement of stratum plus or minus cerebrothalamic loop. Okay, second symptom is?
The second symptom, the behavioral issues, sir.
Hypokinesia, as it was said, hypokinesia.
Yes, sir. I included along with the tremor, sir. So it seems to be slowness of movement, sir. And considering the fact that he also has tremors, it's again extrapyramidal involvement, sir. Probably the striatums.
Okay, as a DMPG, you can still go inside and tell direct path, indirect path like that. Okay, the next symptom.
So the next symptom is the behavioral issues. And considering that it started with anger outbursts and neuropsychiatric issues, and has eventually evolved into a global confusion, sir. It seems to be an encephalopathy, sir. Rather than a particular involvement of any lobe, it seems to be a global encephalopathy.
See, you told three symptoms. Now, one is anger, second is rumination, third is visual hallucination.
Yes, sir.
So you have to localize for each. No, visual hallucination, where we localize?
Sir, visual hallucinations in these cases, it seems to be well formed, sir. So most likely it's the temporoparietal occipital junction, sir. And regarding the anger outburst, probably the temporal lobe, sir. And so initially it probably started there, sir, but it has evolved into a global encephalopathy, sir.
Rumination of thoughts?
Not sure, sir.
There's a default mode network. No, there is a lot of attention network there. So anyway, this localization in occipital, V1, V2, na simple hallucination, V3, V4 means it's a complex hallucination. You can tell like that means generally pericoccipital. Okay. So all these things suggest that there is also cortic involvement.
Yes, sir.
For the past 2 months. Am I correct?
Yes, sir.
Sundar, please, can you go a bit slow, Sundar? You are speaking too fast, a little fast.
Sorry, sir. Visual hallucination, there are simple and complex visual hallucination. Visual hallucination involvement of V1, V2, 17, striate cortex. Complex formed hallucination, most probably it is extra striate cortex, 18, 19. That is present day, it is told as V3, V4 areas. So these areas involvement, lesion, or some damage happens, it results in complex hallucination. Since this patient has a very complex formed hallucination, it is not simple hallucination like a triangle or lines. So it is a complex formed hallucination. Most probably it is a extra striate 18, 19 or V3, V4 involvement.
Okay, sir.
Okay, next symptom.
So next symptom is the urinary and bowel symptom, sir. The patient has history of bladder. Yes, the patient has a history of suggestive of bowel, bladder and bowel retention, sir, along with the presence of pore stream and also the presence of dribbling of urine, sir. So it looks like a lower motor neuron bladder, element bladder, sir, rather than a human bladder, sir. And the possibility could be autonomic dysfunction in this case, sir. If we put together all the symptoms, presence of insomnia and other neurological symptoms, probably it is because of autonomic dysfunctions.
What is the age of the patient? 50, around 50, right?
Yes, sir.
What are your comments about diagnosis of hypertension just at the 1 year before? Is it a coincidence or do you have some comment about this?
Sir, maybe for these complaints, he might have gone to the local physician and maybe got his BP checked, sir. Maybe he's not got his blood pressure checked earlier. That's one possibility. But
yeah. Can be
Bladder
related to this also, right?
Yes, sir.
Autonomic dysfunction, because right at the 1 year in onset,
Yes,
he
sir.
started having hypertension. He was diagnosed of having hypertension. Maybe that one particular recording is a fluctuation or something. We don't know.
Yes, sir.
Any history of OH, orthostatic hypertension?
Not in the history, sir.
Any history of hyperhidrosis?
No, sir. Not in the history, sir.
This autonomic dysfunction is a generalized term, no? So do you want to still localize more for, where do you want to put the lesion for this group of symptoms, urinary bladder symptoms?
I think as of now, we can just say it's a lower motor neuron bladder, sir. I think I would like to examine the case further to comment on the remaining parts, sir.
Bladder sensation feeling was present, not
Yes, present, sir. He was able to indicate that he needed to use the restroom, sir. But because of his bradykinesia, he couldn't walk to the restroom. But he was able to tell his wife that he needed to use the restroom, sir.
so bladder feeling sensation is normal. Am I
Yes,
correct?
yes, sir. And he had
Only-
the catheter only for the urinary retention, sir. Not because.
Main is urinary retention with dribbling incontinence.
Yes, sir.
Okay, so can you tell more under the element? Can you still localize under element, because he is able to feel the bladder sensation? There is no bladder distension.
Yes.
Only retention is there.
Yes, sir. It's predominantly a motor denervated bladder, sir.
Okay, okay. Next symptom.
Sundar, there is a question from UMS regarding bladder.
Is sir, what is the question, sir?
He was not able to pass urine for 24 hours.
Retention of urine. Retention only, sir. Retention of urine.
Yeah, that's what UMS has asked.
Natarajan,
Sir,
24 hours urine passment, this man is, he does not know his whereabouts. How do we come to a conclusion that this is a low motor neuron bladder?
Pushkar,
Yes, sir. Sir, actually, he had not passed urine for 24 hours, sir. So actually, he had gone to the nearby hospital or nursing home, after which but he was able to feel the fullness of bladder, sir. He was very uncomfortable.
If he's able to feel the fullness of the bladder, if he's able to feel the bladder sensation,
Yes, sir.
and he's able to evacuate, where is the lower motor neuron part of it?
Sir, he had dribbling of urine, sir.
But
And
dribbling of urine can be due to an overfilled bladder, not necessarily a lower motor neuron bladder. No?
okay, sir. But he needed a catheter to relieve the symptoms, sir.
Unconscious, almost unconscious, or a lot of Parkinson's where people will need a catheter to drain the bladder out. So just because of that, you can't say that he's got a low motor neuron bladder. Right?
Yes.
In any case, how do you fit the low motor neuron bladder in this symptomatology?
Sir, very poor stream of urine, requiring that he needs to strain while passing urine.
How do you know he doesn't have a prostate, my dear fellow?
Yes, sir. It's possible, sir.
Possible.
So for prostate was batao?
That's what, sir. It's in the the prostate examination was normal, sir, but I shouldn't mention it here. So, and it's only there for the past 2 months, sir. He had no other previous history of any lower urinary tract symptoms.
when he was catheterized, how much of urine was let out?
Sir, around 2 to 2.5 liters, sir. 2 liters. 2 liters.
Considerable amount.
Yes, sir.
Professor UMS, do you want to say anything about it?
He didn't have pain, right? Sir is asking, did he have pain?
Sir, I was a little curious about 24 hours, and you would have had severe pain if the sensations were normal. That was the only thing I wanted.
Yes, sir. Definitely, he did have pain.
He had, okay. Fine.
Okay, continue with the next symptom.
Okay, sir. And the final symptom was loss of appetite as well as weight loss. And considering this has been occurring along with these symptoms, it suggests an ongoing chronic systemic disease.
Did he have a dysphagia also? You said he was on. No.
No, sir. No, sir. We had given him a Riles tube because of his poor intake, sir. But he did not have any dysphagias.
What was the weight loss? Is what significant weight loss?
It is significant, sir. All is old. I had gone through the photographs also, the previous photographs. He had lost a significant amount of weight, sir. But of course, he couldn't be weighed at the time of examination because he was bedbound. But he had a significant weight loss, sir. All his shirts had become loose. His pants weren't fitting him. And
Did he say significant weight loss?
sir, more than 10 kilograms within a period of 6 months, sir.
And at the end, his wife had to buy some new clothes also just to, because they become so loose.
Old clothes weren't
So they
very
had to,
loose.
old clothes to, so yeah.
Okay.
What about the
general-
insomnia, sir? Can you quantify the insomnia?
So the insomnia has only been there for the past 2 months, sir. Usually he sleeps at around 9:30 or 10, but after the past 2 months, he's not been sleeping at all, usually falling asleep only at 1 a.m. or 2 a.m. And even one incident, he had not slept at all the entire night, sir. But it's there only for the past 2 months, sir. But the thing is, the past 10 days, he has become very drowsy, sir. So in contrast to insomnia, for the past 2 days, he's become more somnolent. But earlier to that, it was more of an insomnia, sir.
Insomnia is from 1 year or is it just recent only? 2 years, 2
No, sir,
months, no?
2 months only, sir. 2 months.
2
only.
months.
Okay, next symptom.
Yes, sir.
Sundar, he was saying something about fluctuation. Can we go into that? Or it comes next, is it? Maybe let him go to the next symptom. Pushkar, go to the next symptom.
Yes, sir. Sir, I've covered the important symptoms, sir. So the tremor as well as the bradykinesia.
Hello, why aren't you bold enough to say that these are all the symptoms that the patient has? He has got no more significant symptoms.
Okay, sir.
Pushkar, what about the fluctuation and symptoms? You were mentioning about fluctuations.
Yes, sir. His confusion as well as his drowsiness has been significantly fluctuant for the past 10 days, sir. So the presence of fluctuation could either mean that he's having maybe an underlying metabolic reason on top of his primary disease, or it could be maybe there is a metabolic trigger which is worsening, causing fluctuations, sir. And sometimes he's also having a extrapyramidal syndrome with the confusion. Even Lewy body dementia can also present with extrapyramidal symptoms with fluctuant sensorium, sir.
Were
there is
the
a question.
hallucinations and delusions, where they also fluctuate?
Yes, sir. Yes, sir.
There's a question being asked whether there is a REM sleep behavior disorder or not. I don't think there is any.
No history of
REM
any
sleep
RBDs.
disorder. No, there was only insomnia. There was no any other sleep-related
RBDs.
disorder. UMS sir says that the bladder symptom could be due to pontine disorder also, sir said.
Okay, sir.
That's a bladder symptom.
He also had bowel, no, not only bladder.
Yes, sir. Bowel also, sir.
Constipation.
Constipation, sir.
If content micturition center dysfunction, what will be the patient symptom? Urinary symptom. What is bladder dyssynergia, sphincter dyssynergia?
So there'll be dyssynergia between the detrusor contraction as well as the relaxation of the urinary sphincter, sir.
So resulting in what will be the patient complaint?
Incomplete evacuation, sir.
So there will be any urine urgency, frequency, urgent continence. If it is spontaneous micturition center dysfunction.
So usually urgent continence is usually because of an infrapontine and suprasacral lesion, sir, because of spastic bladder. And
if it is spontaneous, sir is also spontaneous micturition center dysfunction.
Yes,
it will be a urgent continence or it a retention problem.
More of a retention problem, sir, because of the dyssynergia.
There will be also urgency, urgent continence, along with some blood difficulty in blood evacuation with retention.
Okay, sir.
As there is as told, since because of lack of sensory involvement, that is normal feeling of sensation, it could be either motor paralytic bladder or it's a simple BPH, benign prostatic hypertrophy.
Okay, sir.
Because your sensation is absolutely normal, only retention is there.
Okay, sir.
Excuse me, what is the type of bladder you classify this as? An uninhibitory neurogenic bladder, motor paralytic bladder, sensory paralytic bladder? What is the kind of bladder are you classifying this as?
The motor paralytic bladder, sir.
This is motor paralytic bladder.
Sir, his sensation is normal, sir, and he's predominantly having dribbling and urinary retention. So it seems to be a motor paralytic bladder, sir.
Was the sensation normal really,
I-
Dr. Pushkar? I just wanted to ask you, what was the history exactly? How did the bladder symptoms start? Because you told me he was already confused when and catheterized on
Yes.
admission. That's the reason.
Yes, sir. Sir, his
How did
bladder.
he tell you the symptom?
So the bladder symptoms, according to this is based on what his wife had told me, sir, because the patient was
Yes.
confused. So what she had told me is, sir, that he used to go to the restroom and used to keep on straining in the restroom and used to keep complaining back that he's not able to pass urine. Only a few drops had passed, and he still has that sensation that he wants to go. So he used to visit the restroom many points of time, and he had to really strain, sir. But however, he did not have any history of any urge or any stress incontinence, sir, and he was very much aware of the sensation of the fullness. And he also
What would Dr. Pushkar? That's a very nice analysis. What would happen if somebody has detrus or sphincters dyssynergia?
so they'll have the urge to pass urine, sir. But the problem is when they go to the restroom because
That would be very similar to a motor
paralytic.
differentiated bladder in a way. The sensation should be there, and I think that was so. I don't think we can rule that out.
Yes, sir.
But I think we should, in the setting, especially in the setting of what you were describing so nicely,
Yes, sir.
I think we should keep that in mind rather than think of two different areas. Think that this could be somewhere in the pons or the diencephalon. We have to keep that in mind. That's my point. Okay.
Okay, go on.
Okay, sir. So the analysis of the symptoms. So the patient is having predominantly right-sided extrapyramidal syndrome in the form of hypokinesia or bradykinesia and a resting tremor. And then he's also having a subacute onset of encephalopathy and bowel and bladder retention, which could either be because of Pontine involvement, a motor denervated bladder, or even a prostatomegaly. But while putting all the three symptoms together, the possibility of a Pontine involvement or a motor paralytic bladder would be the more likely possibility. But again, the patient is confused. So this is based on the limited history which is given by his wife. So this is the analysis which I was able to make from the
and maybe hypothalamus involvement, loss of appetite, loss of weight.
Yes, sir.
So
Yes,
I think that also that in the same region, no?
Yes.
So keep that in mind.
Yes, sir.
Temporal association, what is the duration of each symptom?
So the extrapyramidal syndrome has been there for a year. The encephalopathy, which is has been there for 2 months, and the bowel and bladder retention has been there for 2 months.
Symmetrical extrapyramidal or asymmetrical extrapyramidal?
Sir, as per the history, it's asymmetrical, sir. He's not complaining of any left-sided symptoms, only on the right side.
Yes. So this is your local lesion, no? So what lesion would cause this?
So probably a contralateral striatal involvement, sir.
Okay. Apart from this anatomical location, we'll go to what is the lesion?
Sundar, 1 minute. Pushkar, you are saying both leg tremors and hand tremors were coast tremors. What do you mean by that?
So the wife was saying that it is very. I think she might try to say that the amplitude was very high, sir. It is very obviously very higher in amplitude, sir.
Okay, you have a video later, isn't it?
I don't have a video of the tremors, sir. I do have video of another finding of the patient, sir.
But you don't have a video of the tremors.
No, sir. I don't have a video of the tremors, sir.
Okay.
No, but Pushkar, when you clinically examine the patient,
Yes, sir.
did it look like a Parkinson tremor?
Yes, sir. Definitely, sir.
So my a little suggestion to you.
Okay, sir.
You just be smart and don't say course. If ultimately you're going to talk about Parkinson tremor,
Yes, sir.
maybe you can avoid the word course and just say that it was a prominent tremor or whatever.
Okay, sir.
Still resting tremor, and just building up your case as you're presenting is much better that way.
Yes, sir.
Nice. Because the point is generally that when you say coarse tremors are generally more proximal and are associated with upper brainstem involvement.
Okay.
So when you talk about that, it sort of makes you think about other tremors.
Okay,
And
sir.
when you say distal course, then if you have found it on clinical examination, I think you should stick to it. But in a way, being just smart and being building up your case as you present, this might be a very good way to go.
Okay, sir.
Right?
Yes, sir.
What is the, this is the local lesion, no? So what is the lesion? What are the diseases that you think of? 1 year history?
Sir, can I summarize the history, sir?
Yes, yes, yes.
Yes, you should do that effectively.
Okay, sir. So the summary of our case is a 55-year-old male who has presented with an initially insidious onset, but then subacutely worsening neuropsychiatric syndrome associated with insomnia, right-sided extrapyramidal involvement in the form of tremors and bradykinesia, with bowel and bladder disturbances in the form of urinary retention, urinary dribbling, and a sense of incomplete evacuation, with associated significant weight loss and loss of appetite, with prior history of systemic hypertension and history of childhood polio with residual paralysis in the left lower limb.
No history of diarrhea, no?
No history of any diarrhea, sir. More of constipation rather, sir.
Okay.
So coming to the differential diagnosis, yes, sir. So coming to the
He has no cave rings.
yes, sir.
Have you looked for cave rings?
I have, sir. I thought I will mention that in
Come in the
the
examination, sir.
we have looked for cave rings.
Okay.
So this is the evaluation at the point of history. This is the differential diagnosis at that point of history taking. Yeah.
And so coming to the differential diagnosis, so since the patient has a constellation of an extrapyramidal syndrome with bowel and bladder involvement with a fluctuant confusion, so atypical Parkinsonism would be a consideration at this point of time, and especially since the patient has had a history of visual hallucinations also, Lewy body dementia would be a consideration. And the second possible cause of atypical Parkinsonism could be a multiple system atrophy. The points towards a multiple system atrophy is the bowel and bladder involvement with extrapyramidal syndrome. But the fact that the patient is confused and has some history suggestive of confusion, which is odd for multiple system atrophy, the more likely DD in the situation of an atypical Parkinson's would be a Lewy body dementia. And the second possibility would be an autoimmune encephalitis. And but however, the fact that the patient has a protracted history for more than a year, which is recently subacute worsened, this is a possibility, but less likely. And considering the patient has significant weight loss and loss of appetite, paraneoplastic encephalitis, which is presenting as an extrapyramidal syndrome with bowel and bladder involvement, as well as encephalopathy is possible. And toxin as well as drug-induced encephalopathies are also possible. And even prion disease can present with an extrapyramidal syndrome with associated confusion, and sometimes certain prion diseases can actually start with visual symptoms like the Heidenhain variant, and the fact that it's been happening over 1 year is also in that situation we should consider CJD also as a possibility. And
what is against CJD?
I'm sorry, sir.
What is strongly against CJD in this case?
There are no myoclonic jerks, sir. But again, myoclonic jerks is usually seen in the terminal part of prion disease. But yes, it's not there in this case, and not in the history, sir.
Pushkar, see this case or any case for that matter.
Yes,
This is a Parkinsonism case, no?
yes, sir.
So your first lead is LBD, diffuse Lewy body dementia.
Yes, sir.
It will be symmetric Parkinsonism or asymmetric Parkinsonism DLBD. Will the rest tremor will be present or not?
Sir, usually in LBD, it will be a symmetrical Parkinson's, and rest tremor is not that common, sir.
So this your patient has asymmetric signs with the rest tremor. So do you still want to put DLBD as the first DD?
No, sir. Those points are against LBD, sir. But the fact that he is having confusion, fluctuant sensorium, and also visual hallucinations.
So approaching a Parkinsonism is first is how do you classify Parkinsonism?
Sir, typical and atypical, sir.
Okay, primary Parkinsonism, secondary Parkinsonism, Parkinson plus.
Yes.
So this under this if it's an asymmetric with the rest tremor, you go for first Parkinson's disease. So what are the points against Parkinson's disease for this patient?
So the presence of confusion and bowel and bladder symptoms within 1 year of the onset of extrapyramidal features is against typical Parkinson's, sir. And also the very rapid progression of symptoms is also against Parkinson's. So
rapid progression of symptoms and presence of autonomic symptoms within first 1 year. What are the non-motor? What are the non-motor symptoms of Parkinsonism where which can come early?
Sir, anosmia is one of the earliest non-motor symptoms, sir. It can probably precede the Parkinson's.
Among your patient's presentation,
In this,
can
yes.
sleep disturbance, can autonomic symptoms can be taken as non-motor symptom?
Sir, actually, RBD can precede Parkinson's, sir. But of course, there is no history of RBD. Insomnia also can occur, sir. But again, the insomnia, the sequence, it's after the onset of extra syndromes.
Yeah, while on that point, Pushkar, there are two aspects. I think a little clarity would be good.
Okay, sir.
One is, what was the medication you started on? And was he started on medications earlier? And what
No,
were
sir.
there, if at all, any relationship chronologically to the hallucination? It's important to mention
Yes, sir.
that as part of the treatment history
Okay,
in a
sir.
patient like this. So, that dopaminergic agents can produce visual hallucination. So we would first keep that in mind. Number two, while we are talking about sleep disturbances, it's good to ask about finalistic behavior in sleep.
Okay.
And does he enact out, not just RBD.
Okay, sir.
It could be finalistic behavior. These are all pointers, especially in relatively rapidly progressive Parkinsonism. So I think those two might be useful.
Yes, sir.
Yeah.
Did he start any medications? Because his complaints about 2 months, right? 2 months is rapid
Yes, sir.
worsening. So
2
along
months
this,
is- yes, sir.
around this 2 months worsening, just before this, prior to this 2 months, was he started on some medication or something?
No, sir, he has not gone. He's not taken any medication, sir. His only hospital visit was to get the catheter, sir. Otherwise, he's not got any other medications.
So despite this degree of illness, he has not been to
No,
hospitals.
sir. No, sir. Even for his earlier cough, which he had around 1.5 years ago, he had not sought any professional medical help. He had only taken native medications, sir. This is his first visit to a allopathic hospital.
Oh, so he had some reluctance towards the allopathic hospitals. Okay, fine.
Okay. So this is one way of discussing Parkinsonism as primary, secondary, and partial class.
Yes.
You want to tell pathology wise in the history of this 1 year duration, the sudden worsening last 2 months.
Yes,
What pathology you want to put first? You want to put neurodegenerative, or you want to put any other pathology to account for your localization?
Sir, neurodegenerative sometimes is also possible, sir. But again, because it's a 1 year history, we should also keep in mind paraneoplastic as well as autoimmune encephalitis, sir, because that should be a consideration, sir. Even though atypical Parkinson's sometimes can present as a rapidly progressive syndrome, but it's important to rule out any other reversible etiologies, since it would change the therapeutic perspective in this case. So keeping autoimmune encephalitis and paraneoplastic encephalitis at least as the same equal importance as atypical Parkinson's will be important in the DDs.
Okay, so the onset is progression is very important to tell pathology. No, so this onset is 1 year and it's rapidly progressive. So
Yes.
more than neurodegenerative as a first diagnosis, you can keep the secondary cause of Parkinson's first. And because of his significant weight loss history, as you said, some paraneoplastic encephalitis involving Parkinson could be the better one than a neurodegenerative. Under neurodegenerative also,
Yes.
it's just LBD where two things should be there. One is symmetrical Parkinsonism,
Yes.
and absent there is no rest. There is here this patient is rest tremor. These two are against. But as I said, visual hallucination and fluctuating cognition in a single day can go for DLBD. They are core criteria for DLBD.
Yes.
But my point is whether it could be early onset Parkinson's disease itself with the autonomic symptoms. It could be a non-motor symptom.
But since the onset, it's very soon now. So within 1 year, he's developed the other symptoms, sir. So it's and there's no prior history of this complaints. So if it's present within 1 year, I think primary Parkinson's or typical Parkinson's would be the unlikely scenario, sir.
Yes. Okay. One of the red flags for PD is the autonomic dysfunction, mismatch, the two incontinence mismatch symptoms within 1 year.
Yes.
Accepted. And also this cognitive worsening is also within 1 year, no? Cognitive worsening.
Within 2 months, actually, sir.
Okay, so we can put secondary Parkinson's under than because of weight loss history, paraneoplastic encephalitis might come earlier.
Okay, sir.
Or autoimmune.
Yes, sir.
What about the other etiologies what you enumerated? Prion, as Sarah told, there is no myoclonus. Any
Yes.
toxin drugs which can cause Parkinsonism with the cognitive, with the autonomic.
Drugs, sir.
Drugs and toxins.
Sir,
What
heavy
the drugs which can cause Parkinsonism, what are the toxins which can cause Parkinsonism?
Okay, sir. Sir, drugs, most of the antipsychotic medications, sir,
Yes.
or psychotropic medications can cause drug-induced encephalopathies. And patients who have GI symptoms, we have to ask him, we have asked, sir, but any chronic use of any antiemetics like metoclopramide.
Can a drug-induced Parkinson present with a rest tremor? Asymmetrical rest tremor?
No, sir. Usually it is bilateral and usually bilateral, sir. It is usually symmetric, sir. Drug-induced Parkinson.
Most of the other etiologies, toxins, prions, sorry, metabolic, they most of the diseases, they present as symmetrical Parkinsonism mostly with
Yes.
absence of rest tremor. Only
Unusually they can present as asymmetrically.
unusually is only two things which is come with the asymmetrical rest tremor is one is PD, second is not the tremor but asymmetrical CBD.
Okay, sir.
Can it could be corticobasal syndrome?
Sir, there is no other features of CBD, sir. There is no dystonia, no myoclonic jerks, there is no clear-cut other apraxias in the history, sir. But again, he was confused and the wife was taken from the history, sir. So the possibility can't be ruled out, sir.
Okay, the presence of rest tremor. Yes, sir.
No, I have a question.
Yes,
See,
sir.
we have been discussing about the tremors, we have been discussing behavioral issues, we have been discussing autonomic functions, and the last one, confusion. But what about the gait? Pushkar, can you tell us something about his gait in between? How was he moving around?
Yes, sir.
Was his gait affected at all? That should probably provide a clue.
Sir, actually, by the time he had come to us, he was totally bedbound, sir. But when I asked his wife about that, the only thing that she would mention that he was slow to walk. And especially on the right side, sir. But otherwise, there was no specific history we could get about the gait, sir.
He was still moving around.
He was not moving around for 2 months, sir.
I'd like to add one more comment, Pushkar.
Yes, sir.
Although we have been trained, right, that principle holds on the most of the points it holds true. We try to explain all the disorders by a single etiology. Have you considered at least a possibility at this time that patient is having a classical Parkinsonism for last 1 year and some other diseases also happening for last 2 years? Say it's a metabolic disorder is happening for last 2 years in a patient of Parkinson's disorder, or he has developed some other disorder in PD. I will just say that you should at least consider that at this level.
Yes, sir, that is possible.
I am not saying that you disregard the principle of parsimony. You should follow it till the end. But
Okay.
there are exceptions to principle of Parkinsonism, which can lead to the possibility, at least a rare possibility, even though
Yes,
that
sir.
patient, a Parkinson's disease patient has developed something else.
Yes, sir.
That should also be considered at least. Okay. So first you will try to explain everything by a single disorder, and then you can try to explain it this way also.
Yes, sir.
Because suppose the patient of PD starts taking drugs and he develops a psychiatrical illness in the last 2 months because of many antipsychotics he's taking, it still can be explained. Okay.
Yes.
So that is one, just a comment here at this.
Okay, sir. Sir, and the final one is, of course, definitely this is not a primary metabolic encephalopathy, but considering the patient is having a recent worsening of his sensorium with the fluctuant course, a superadded metabolic cause for his encephalopathy should also be considered at this point of time. But as Sir said, secondary Parkinson's would be the first differential diagnosis, followed by atypical Parkinson's and paraneoplastic encephalitis, and possibly drug-induced encephalopathies. And least likely possibilities would be a slow viral disease or a prion disease.
On the prion, which will present with visual hallucination?
Sir, Hayden invariant, sir.
Very good. Okay, if anybody wants to contribute, or we'll go for example. Sir, VM sir, we'll go for examination.
Yes, you decide. Yes, I asked what I wanted.
Okay, we'll
Maybe
continue.
we'll get more clues from the exam.
Sir, I'll proceed, sir.
Yes.
Okay, sir. So coming to the general examination, the patient was clearly confused. He was not oriented to time and place, but however, occasionally he was able to recognize his close family members. And when I had gone to examine the case, it was around 7 p.m. in the evening. And
he was bedridden and not able to walk, right?
Yes, sir. He was bedridden and not able to walk, sir. And he had his GCS was 14/15, losing 1 score in confusion. He was afebrile, and on his admission vitals, his baseline blood pressure that is entered in the OP chart was 140/90. But on IPD, we had monitored his blood pressure and vitals, and we noted that it is very much fluctuant. His systolic BP was varying from 90 to 170, and his diastolic BP was varying from 60 to 110. But the thing is, because it is so fluctuant, we were not very sure whether the fall was because of the postural fall. There was no significant postural fall in BP, sir, because even without that, the BP and pulse rate was very much variable. His OP record pulse rate was 90 per minute, but
No, posture you couldn't examine, right? He was bedridden, right?
he was bedridden. So we could make him sit up, sir. We couldn't make him stand, but we made him sit up and check the BP. But there was no further postural fall in BP other than the baseline fluctuations, sir. And his pulse rate was 90 per minute. It was regular. This is as entered in the OP chart, but on further IPD examination monitoring, it was noted to be very much fluctuant, with the lower limit being 60 and the upper limit going all the way to 130. But through this fluctuation, it was regular. He was not in respiratory distress. His saturation was 98% in room air, and his respiratory rate was 12 per minute. So coming to the neurological exam, the patient was clearly confused. So an MMSE or a detailed cognitive examination was not possible in this case. And coming to his cranial nerve examination, his fundus exam was normal, and his vestibulo-ocular reflex and the extraocular movements, which was done, albeit with some difficulty, was noted to be full range. There was no primary gaze deviation. And during the cranial nerve examination, he was noted to have a decreased blink rate and also mask-like facies. There was no obviously noted jaw or facial weakness. The jaw jerk was absent. His uvula was central and his gag reflex was intact. There was no obvious tongue wasting or fasciculations and no obvious weakness. But again, the cranial nerve examination was done in a patient who was confused. So the spinomotor examination.
Pushkar, you have to tell the KF ring here, okay?
Okay, sir. Sorry, sir. The KF ring was absent.
About this thing, KF done visually as well as by slit lamp examination was negative.
Yes, sir.
Slit
The
lamp
KF ring was
not, I don't right.
Yes, sir. The KF ring was absent, sir. Sorry, I have not mentioned it, sir. The spinomotor examination, the bulk, there was a left lower limb wasting as well as a left ankle contracture, and this is probably because of the residual paralysis from
eye movements, Pushkar.
Yes, sir. Sir, actually, the eye movement exam was done with a lot of difficulty, sir. So actually, we had done the what we had done is, like, we had just asked him to follow some simple objects or some flashing light. There was no any skew deviation or any other eye deviation in the primary gaze, sir. There were no very obvious there's no obvious ophthalmoplegia which is there, sir. And his pupillary examination also was normal, sir.
Okay. Right.
And his VOR is intact, sir. His vestibulo-ocular reflex is intact bilaterally. And yes, sir. And this left lower limb wasting and his left ankle contracture is probably because of his residual paralysis from his childhood poliomyelitis. And on examination of the tone, we could make out that he had bilateral, in contrast to the examination, he actually had rather bilateral upper limb as well as lower limb cogwheel rigidity, but it was more on the right side. And coming to the power, again, a detailed examination of the power was difficult in this case, but however, he was moving all his limbs, but there was some positive movements in his left lower limb. This is probably because of his previous poliomyelitis. And his deep tendon reflexes were 1+, except in his left lower limb where it is absent, again, yet because of his previous polio. Superficial reflexes were intact, and a detailed examination, detailed sensory examination was not possible in this case in view of confusion. However, he was localizing to pain, and but otherwise a detailed sensory exam was not possible. And cerebral examination again was done with a lot of difficulty, and it was and the right side also it was difficult to assess because of his already pre-existing extrapyramidal syndrome, but there was nothing grossly abnormal. There was no nystagmus. And coming to the tremors, it is noted in the right upper limb and lower limb. These were high amplitude tremors, low frequency, around 4 to 5 hertz, predominantly present in the wrist. It is distal predominant. It is present at rest. There's no significant action, postural or kinetic component to the same. And as mentioned earlier, it is associated with cogwheel rigidity, but this is more on the right side compared to the left, and it was associated bradykinesia. But the bradykinesia,
So there is a little disparity here.
Yes, sir.
So you can't say coarse and high amplitude in the same thing. No, it's pretty one actually obviates the other.
Okay,
rules
sir.
out the other. If you have high amplitude, then and the low frequency. Low frequency is not 4 to 5 hertz.
Okay, sir.
So it's going to be still lower. So when you say 4 to 5, course, okay. And the character of the tremor again, was it supination, pronation? Was it extension, flexion at the wrist?
Sir, it
Was
is
it only the fingers
it is a flexion extension, sir.
at the wrist?
Yes, sir. At the wrist, sir.
No supination, pronation.
No, sir. It is predominantly flexion extension.
Okay.
And also there was some finger tremor also, sir. Finger flexion and extension also.
Okay. Good. Okay. Right.
Okay, sir.
Fine,
So, but tremors are only on the right side, sir. But the cogwheel rigidity as well as the bradykinesia was bilateral, sir.
Bilateral. Yeah. Good. Okay.
Okay, sir.
What about the lower limb tremor? Lower limb tremor is, was it flexion and extension?
No, sir. It was dorsiflexion, plantar flexion, like that, sir. The distally present in the feet.
Distally, proximally, so there was no.
No, sir.
tremor at all.
No, it is distal, sir. It is distal
Because
predominant.
it started from the lower limb.
No, sir. Actually, it started in the lower limb, sir. Later, no, sir. The tremor actually was present both in the upper limb and lower limb at the same point of time, sir.
Because you said very significant. I was thinking from the beginning that was very significant because it started from the lower limb.
Okay,
It was
sir.
very unusual. Yeah.
Okay, sir. His slowness while walking, yes, that did start in the lower limb, sir. But tremors, according to his wife, was both, sir.
You
But
said
he has
it
an
was
ankle.
lower limb.
He has an ankle contraction now, Pushkar.
So that is on the left side, sir.
Left side.
Yeah. Okay. Right. Not on the right side.
Not on the right side, sir.
Right. Okay.
Okay, sir.
No, I'm just asking that does the ankle contracture mask a tremor on the left side? How do you know?
That very much could be a possibility, sir. But he did not have any upper limb tremors, sir. So
But totally can't be sure. Pointless. Okay.
yes, sir. The patient did not have any meningeal signs. Cranium and spine examination is normal, and there was no obvious peripheral nerve thickening. However, at the time of routine examination, we had noted these abnormal movements of the muscle. So here we can see there is persistent involuntary rippling movements involving the thigh. So I have particularly videographed the thigh, but actually these movements were present over the shoulders, the arms, as well as the abdominal wall. We can see these persistent rippling involuntary movements, which was painless according to the patient, but again, he was confused. So, and this appears to be myokymia, sir. Playing it again.
There is no history of pain, right? Anywhere there is no history of pain.
So the thing is, again, he was confused, sir, but he didn't seem to be, and since he didn't complain of this, so I'm guessing, I'm assuming it is not painful, sir, because he did not complain of this complaint at all. So I'll play it again once more. Is it playing, sir?
This the moment is still the
No,
patient
sir.
may tell.
No, sir. No, sir. Not at all, sir. Even when I asked him retrospectively, also he did not. They were not aware of it at all. It is only when I showed them that they. I think they were more concerned about the tremors, sir. So I think probably they did not come out with this.
So what could be this movement, involved movement? Which
Did
was narrow
he have
down
any? Yeah, did he have any tactile myoclonus?
Tactile myoclonus, sir? No, sir. Not.
No, on touching and tapping.
There was no myotonia, sir. I don't know.
The myoclonus.
No, sir. I think I have not checked for it, sir. I didn't check for it.
So describe this movement and tell what is it, DD.
Yes, sir. So this is a persistent involuntary rippling movement, which is present over the thighs, the shoulders, as well as the abdominal wall. It appears to be like myokymia, sir. It appears like a myokymia.
Is it
You
fasciculation?
can you described it very well. You can confidently say this is myokymia.
Myokymia, sir.
Because you said rippling. That's the word. You described it very, very well. You say this is myokymia.
Okay, this is myokymia.
Yes.
What is the total duration of this involvement? If you are put a leading question and ask them, it was present 1 year or it was present recently?
No, sir. They had not come out at all with this in the history, sir. Even on retrospectively going back to the history, also they did. They were totally unaware of this. They were not. This was not a complaint at all, sir.
No cramps,
No, sir, not at all, sir.
no hyperhidrosis, any sweating
No,
abnormalities.
sir, no, sir, no, sir. They did not come out to this history, sir. This was noted during the routine examination, sir. Even while asking them, putting leading questions also, they were rather puzzled when I showed them this. So they weren't aware of it, sir.
So from the history, this is the only one finding which is
Extra, sir.
new one.
Yes, sir.
So where will you localize for this?
Sir, I think after seeing this finding, the differential diagnosis is narrowed down a lot. So since the patient is having myokymia with extrapyramidal syndrome, with insomnia,
Myokymia, where you localize? For discussion sake, myokymia, where you localize?
it's a peripheral nerve, sir.
Peripheral nerve is a very big term, no?
Peripheral nerve hyperexcitability, sir. So nerve end, sir.
It is the terminal or axon, motor unit.
Sir, axon, sir.
Not necessary. Anyway,
Axon, sir. Myokymia, it's usually the axonal end, sir.
unless you prove that it is from the axonal end, then it becomes a very difficult thing to say that myokymia arises only from the
Okay, sir.
axonal end, you see.
Okay.
There are several types of dribbling and which take origin from anterior horn cell to local peripheral nerve itself. But anyway, go ahead. Let's see what you come out of it.
It's a sign of denervation. Okay.
Okay, sir.
Possibly. I don't know whether you can call it a sign of denervation or you can say whether a sign of hyperactivity. Very difficult. If it is a
Yes, sir.
fibrillation, yes, you can say confidently sign of denervation. But a myokymia, I don't know. We'll wait and see.
Wait and see. Yes.
Okay, sir. Shall I proceed, sir?
Yes, proceed.
Thank you, sir.
Now, what is your diagnosis? Since it narrowed down with myokymia, a patient with Parkinsonism, asymmetric Parkinsonism with the cognitive disturbance, with the autonomic symptoms, with the myokymia.
So my first diagnosis would be peripheral nerve hyperexcitability syndrome, and considering the coexisting encephalopathy and everything else, it's a Morvan syndrome, sir.
Casper 2.
Especially with the significant
Myokymia.
fluctuations in BP. Yeah.
Yes.
How common is Parkinsonism in Morvans?
Sorry, sir. I couldn't get it, sir.
How common is Parkinsonism or Parkinson's signs in Morvan syndrome?
Sir, it can occur, sir, but it's not a very common symptom, sir. Usually, it is more of pyramidal signs, myokymia, insomnia, bladder and bowel involvement. It can occur, sir, but it's not a very common feature of Morvans.
All along, your presentation was around Parkinsonism. Am I correct?
Yes, sir.
Now, this myokymia is there, which can account for all this later 2-month symptom.
It can, sir. But again, the Parkinson's.
That is a 1-year symptom. So you are trying to tell that for the last 1 year, he has Morvan's disease, and that is the cause for this Parkinson, that external symptoms and this present symptoms. Are you trying to tell that, or you want to put 2 diagnoses?
So that is a possibility, sir. But again, as you had mentioned, sir, especially presence of asymmetric Parkinson's in Morvans is not a very common thing, sir. Another possibility is maybe he actually had an idiopathic Parkinson's and he has got a Morvans now, sir. Maybe it's just a coincidence, sir. That is also a possibility.
What about the possibility of Parkinson's with indigenous treatment?
So that is also a possibility, sir. So
I didn't get you nuts.
Yes,
Sir?
sir.
I didn't get you.
No. He had treatment with indigenous medication, probably Ayurvedic treatment, prior to the onset of all the symptoms.
Yes,
You're
sir.
talking now. You're talking harshly now. I mean, yes, you'll have to take that into consideration,
Yes, sir.
especially with symptoms of Morvan's and Parkinson's. And what would augment my thinking process if he's getting better after cessation of medicine?
The problem was that he stopped the medication 6 months prior to the onset of symptoms.
Yeah, but still, if you have damaged all the tissues, what's the point in stopping?
Yeah, might be. And Parkinson's history itself very dicey. It might have started instead of 2 years back,
Let me put
one
it,
year back, it might
let,
started
let,
1.5
let
years
me
back.
put
We
it,
don't know.
let me put it this way. Are the symptoms progressive or
Yes.
not?
Yes.
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 Yes. And these behavioral issues and cognition disorders have appeared only in the last 2 months.
Hmm.
So that temporal relationship is was a big problem. We thought of that definitely.
When was the indigenous drug intake? When was the Parkinson symptom? When was this
Yeah.
symptoms?
Yes, sir. So that is around 2 years ago. That is 1 year before the onset of symptoms. He has taken these native medications, sir, for a period of 6 months intermittently. So he had stopped these medications 6 months before the onset of Parkinson's, sir. So from medication time to onset of the extrapyramidal syndrome is 1 year, sir.
But
Which indigenous medicine can cause Parkinson, leave alone Mormons?
Okay, sir.
What indigenous medicine can cause Parkinsonism symptom?
Sir, one antihypertensive, sir.
Indigenous medicine only you took, no?
Yes, sir. Both Siddha and Ayurveda, sir.
They can produce,
Sir, certain Ayurvedic medications can, sir, especially the antihypertensive medications. But sometimes during the preparation of these components, there can be contamination of mercury and other heavy metals, sir. Those can cause Parkinson's, sir, rather than the medication per se.
Oh, because Mormons, we can put indigenous medication use as the etiology or any other autoimmune etiology, but Parkinson's it's a hitch point. 6
Sir,
months
may I
after.
come in? May
Yes,
I
sir.
come in, please?
Yes, sir.
I don't think we need to be worried much about the temporal association. It is well known that these symptoms can occur even 1 to 2 years after the stoppage of Siddha medication. 1. At present, we have a patient like this in our hospital. 1. 2. Regarding calling it Parkinson's disease, I don't know why we have to call it Parkinson's disease. These are features which are resembling Parkinsonism, that's all. And they can very well occur in following Siddha medicine and native medicine intake. And we at present have a patient like this. Exactly what you described. The most striking feature is the insomnia. Sometimes they never sleep at all for days together or weeks together. And that is the most striking symptoms. Of course, pain is there. As he pointed out, pain, the patient did not tell, even our patient was not very significantly complaining about the pain. And of course, we made out this fine rippling movements. And then we asked for a autoantibody test and it was strongly positive. So, and in fact, I would also, if they have done an MRI, in fact, my first diagnosis, even before this patient was he had a lot of these abnormal movements, not fitting in exactly to a Parkinson tremor, but he had some myoclonus also, predominantly intention. So initially I thought I was dealing with the CJD. Then the wife came and told me that he was taking Ayurveda or Siddha drugs, which later on only we came, and then we asked for this VGKC and it was strongly positive. So exactly a similar case we have at present in the hospital. So I don't think we need to put two different diagnoses in this case. And drug-induced symptoms can occur even after 1 to 2 years. After stopping the medication also can keep on continuing.
Vijayan, can I ask you what metals were involved in your patient?
Sir, what, sir?
Which heavy metal was involved in your patient?
Which, sir?
Which heavy metal toxicity was involved in your patient?
No heavy metal, sir. Most of these cases, they don't come, we look for, I've stopped searching for heavy metals in these patients, sir. Long back.
It was negative or it was...
No, we stopped looking for heavy metals. We just ask for VGKC nowadays. We stopped looking for heavy metals. We stopped. Most of the time, we look for heavy metals. There is no evidence of heavy metal poisoning in most of these patients. It's all VGKC
most of them
positive.
do have most of them do have raised lead, mercury, arsenic.
Vijayan, then what was the relation between Casper-2 and the indigenous medication intake?
That has been well pointed out, no, sir. Already, it's a
what is the relationship? How does it bring it on?
it unmasks probably it unmasks the autoimmunity. That is the
So
only
this
thing
is this
which
is
was
what
brought out, I think.
this is what we presented with 14
Yes,
patients
with the green
who had,
mamba. I
yeah,
remember
yeah,
that.
in Mumbai, and we
No,
presented.
several
And we
such cases have been
postulated,
described.
sir.
All of them
Sir,
have been
very true, sir.
following
We only
Ayurvedic.
postulated. Sir, we only postulated that this is probably unmasked. Nobody knows
postulated.
clearly. No definite theory of how it comes.
So
I
at
think
this
it was
junction,
first.
yeah.
As all of us
This was,
know,
sir.
Bala had shown mercury poisoning in these cases. Sorry, Lima, என்ன சொல்றீங்க? Lima, you wanted to say something? Okay.
Sir, only one thing. I think it was first described in India by Panagaria.
Correct. All that is right.
Panagaria, and then later on Professor
Yeah, we've
Liomas
gone through this several times.
Yeah.
We've gone through this several times. The only thing is, again, we bring in indigenous treatment and link it to Casper 2. And sometimes, as I said, particularly from Institute, mercury had been found out. And so also, I think Prakash had mentioned from Coimbatore, he had also mentioned some relation to heavy metals. So,
Casper 2, yeah.
Pardon?
Casper 2 usually has pain, sir. It has been mentioned and the other check is painful, like, but there was absolutely no pain in this. Second was obviously heavy metal, and third was
The spectrum of Casper 2 is expanding pretty well.
Yes.
Now
Yes.
we have isolated cerebellar ataxia. We have only isolated falls. The Casper 2 is expanding like nothing. So I don't think in this patient, with 1 year where the patient became bedbound without a paralysis and primarily with these complaints, I think it fits pretty well with more ones. I think many of his disability could be due to the autonomic dysfunction too. We
will, sir, in the subsequent slides, we will discuss all about this temporal relationship, autoimmune etiologies, and impact of these etiologies.
When we say weight
we
loss,
have,
just a quick pointer. When we say weight loss and a rapidly progressive movement disorder, especially with sleep disturbances, autonomic and everything, then there are some syndromes autoimmune that we would think of. And Morvan's is one. You think of Iglon 5. We would definitely think of anti-DPPX, and it has been defined with anti-NMDA too. So these are the ones that commonly present like this. And those were some of these questions, like I asked for phenolestic behavior, it's for Iglon 5. So the tactile myoclonus would be a very, and the history of diarrhea would have been a pointer for anti-DPPX. And if you have myoclonus someplace, CRIM5, especially in a male with the breast cancer and male breast cancer can present with CRIM5. That's a stiff person-like syndrome. And so you can present with Parkinsonism, a stiff person-like syndrome, which can be asymmetric with some myoclonus. So these are general differential diagnosis for these syndromes.
Yes.
Just my thoughts. Thanks.
Yes. Thank you, sir.
Thank you.
So two more questions, sir. All this, whether this patient finally mercury directly causes all these symptoms, or mercury causing autoimmunity, causing all these problems.
So we will come to the diagnostic testing and all those things. So we will keep something open for that.
Okay. Then another question is
diagnosis and all those things. That investigations will come. That part will come in details.
Okay. Another point is, among these autoimmune Casper everything, what is the temporal profile? Is it subacute or chronic? Like
So
1
that
year?
we have separate discussion in this. The temporal part we have a discussion on that, and review of literature also. So we'll just wait for 2 slides. I think it will not be nice. So we have proper slides for that, and detailed discussion on what does the temporal discussion mean.
Because I also want to reiterate, like you must have told, long means Iglon 5 and DPPX should be taken into long duration.
Okay.
1 year history. With short duration, Casper 2 might be the first one, but it's a long history. Iglon 5 and DPPX could be one possibility. That's one more point.
No, I had not considered these 2 things. Yeah, we'll see.
Phenotypes are a bit different. Okay. Anyway.
So shall I proceed, sir?
Yes.
So coming to the final clinical summary of our case. So he's a 55-year-old male who was presented with an insidious onset and a subacute worsening of neuropsychiatric features, insomnia, myokymia, bilateral but asymmetric right side more than left extrapyramidal involvement with autonomic dysfunction in the form of heart rate and blood pressure fluctuation and bowel and bladder disturbances with associated significant weight loss of appetite, with a prior history of systemic hypertension and prior residual paralysis from childhood poliomyelitis. And
Myokymia also, right? Yeah.
I mentioned that, sir. Yes.
Yeah. Fine.
And so putting the constellation of these symptoms together, we can say that there is bilateral extrapyramidal involvement, there's a subacute encephalopathy, autonomic nervous system involvement, and peripheral nerve hyperexcitability in the form of myokymia. And the first and most important differentiation in this case would be Morvan syndrome. But the fact is, whether it's a primary Morvan syndrome, whether it is a primary Morvan syndrome or it's secondary to some other etiology. So coming to autoimmune encephalitis, Morvan syndrome is most commonly caused by an anti-LGI or an anti-Casper. But the other differential diagnosis that we also should keep is an IG-LON5, because these patients also will have some sort of REM sleep behavioral disorders and insomnia, but of course RBD is not present in this case. And the other one will be DPPX encephalitis. The points towards DPPX encephalitis is the fact that he's a middle-aged male patient and he's having significant weight loss, but DPPX usually will have diarrhea, which is not present in this case, and rather here the patient is having constipation. And paraneoplastic etiology of Morvans also should be considered, and toxin-induced encephalopathy, especially that is due to mercury. So mercury is a very common heavy metal that is associated with Morvan syndrome, and many of times the mercury toxicity which is associated with Morvan syndrome is sublethal because it's not primarily because of mercury toxicity, rather a central nervous system autoimmunity that is triggered by mercury. And usually in this scenario, it is an anti-VGKC or an anti-LGI or anti-Casper2 encephalitis. Sir, now I'll be proceeding regarding how we had evaluated this case. So first, coming to the basic investigations, the complete hemogram was normal, the hemoglobin total count and platelet counts. And coming to the renal function tests were normal. However, the patient did have a hyponatremia, which can be present in, which is commonly reported in Morvan syndrome, but it can also be present in other autoimmune encephalitis, like IG-LON5. And
excuse me, can you show me the whole picture as a whole, the patient as a whole? Whether in a lying posture or a sitting posture, or as Professor Natarajan pointed out, an attempt to make a gait or something like that. Can you give a full picture of the patient?
Okay, sir. So basically, he's a 55-year-old male, sir, who was
We don't have that video or photo of whole picture. No? That is what I think sir is asking.
Sorry, sir. I don't have any, other than the myokymia, I don't have any other videographs or photographs, sir.
Okay.
The myokymia was in standing posture, isn't it, Pushkar?
No, sir. He was not able to stand, sir. He was bedbound, sir. This is noted in supine position.
Okay. Thank you.
So otherwise, the electrolyte...
Natarajan?
Yes, sir.
Hello?
Yes, sir.
Natarajan?
Yes, sir.
What is the incidence of involvement of the hemispheres in patients with Casper syndrome? Did you get my question?
I got it, sir. What is the cerebral involvement in Casper syndrome?
Yeah, basically.
As has been pointed out, basal ganglionic involvement might be there, sir. But apart from that,
is it in Casper syndrome? Does it go to the extent of
cerebral cortex?
Cerebral cortex, dementia, sleepiness, all this?
Yes. Okay. That is why IG-LON5 was brought in, sir, because if it's a diencephalic involvement, some of these pictures could resemble a cortical involvement, isn't it, sir?
Sir, if I may, sir.
Please.
Sir, Casper2, as I mentioned, sir, the spectrum is growing, sir, and there have been some reports of even frontal lobe involvement in Casper2. But it predominantly has been described as one with peripheral nerve hyperexcitability.
That's right. That's
But
right.
but there is involvement, sir, but
You're hitting
more
the
and
point.
more, so more and more, more and more descriptions have come out about cerebellar involvement, brainstem involvement, frontal lobe.
That's still peripheral. I mean, you in the sense that main hemispheres are not involved. There's no cortical involvement. There's no confusion. There is no question of a dementia. There is no consideration of other things. Basically, Casper syndrome is where you have a primarily a low motor neuron involvement, hyperactivity. If I get it right, that is why I asked the question: what is the incidence of higher more functional involvement in patients with Casper syndrome?
So I think we are still learning, sir. It is still
You
now
don't
been
know.
described. Yes, sir. We are still learning about Casper, and the spectrum is widening.
In that case, do you think something else has to be thought of also?
No, sir. I think in this case, if Casper is positive, it should explain most of the symptoms that.
Because I have a point. Because recently, Casper syndromes are treatable.
It is, sir. It is.
It is.
At least in most cases,
But
it is.
It is treatable. Either you give him IV, or you give, I mean,
plasmapheresis,
antibody.
steroids. Yes, sir.
Steroids, whatever. I mean,
Yes.
Immune modifying drugs.
Yes, sir. Immunomodulation. Yes, sir.
Now, has this been done in this patient?
We'll wait, sir. We are not gone to that stage, sir.
We'll wait and see.
I'll come on that. I'll come to that, sir. And coming to the continuation of the routine investigations, the RFT, the RFT and the LFT were normal, other than some hyponatremia, and the CPK was elevated at 580, probably because of the persistent myokymia. The liver function tests were within normal limits. However, the patient did have a low serum protein as well as a low albumin. This could probably be explained probably in parallel with the patient's weight loss and loss of appetite and his poor nutritional status. Coming to the CSF exam, the patient did not have any hypoglycorrhea. There was a upper normal CSF protein. There were 10 cells, all of which were lymphocytes. Chloride and ADA were normal. HSV and PCR were negative. AFB as well as CBNAT were negative. Cultures were sterile, and cytology did not have any malignant cells. So the CSF analysis was essentially it was normal. And the thyroid function tests were normal. And as Sir had mentioned, the first thing that we thought of was an anti-VGKC encephalitis. But surprisingly, both the CSF and the serum autoimmune panel, which is sent to NIMHANS, were negative for LGI as well as negative for Casper, and the remaining panel also was negative. But again, around 50% of the patients with Morvans can be negative for LGI and Casper. So also sent a paraneoplastic panel because paraneoplastic encephalitis was the second consideration we had as a cause of Morvans, but it was negative. The entire profile was negative. And we did a heavy metal screen, number one, because the patient had a prior history of native medication intake, and there were several case reports of mercury toxicity associated with Morvans. So initially we had sent a urine mercury, which was significantly elevated. It was 171.6 with the normal biological reference being less than 20. And
what about MRI? MRI.
I'll come to that, sir. I put it up, sir. And so to confirm this elevated urine mercury, we are also sent a serum mercury, and it is also elevated. It is 10.19 with the biological reference being 0.46 to 7.5. The rest of the heavy metals was negative.
It's a very wide difference, but still higher than even 7.5.
Yes.
Is kind of
yes, sir. The serum mercury reference is actually very wide, sir. It's all the way from 0.46 to 7.5. But our patient's value was even more than 7.5, sir. It was 10.19.
Where did he get?
Sorry, sir.
Where did he get his mercury from?
Sir, actually, we had reviewed all the native medications, sir. There wasn't any mercury as a component in it. And we have also sent a request to his local area to get his well water checked, sir, because actually they predominantly consume this water source in their house is not bore water. Actually, it is well water, sir. So we have actually sent, we are waiting for the well water mercury reports. It's pending, sir. And our second consideration is probably mercury contamination from his native medications. Even though per se the Ayurvedic and Siddha medications, especially Siddha, don't have mercury as a component, but during the preparation there can be mercury contamination, sir. So it's either one of these two, sir. It's either the well water or the native medication. But in this case, most likely native medication, because the other family members who also consume the same water for all these years don't have any symptoms yet, sir.
Great.
And the rest of the heavy metal screen was negative: cadmium, chromium, lead, as well as arsenic, all were normal. And remaining of the investigations, so coming to electrophysiology, the nerve conduction of all four limbs was normal, other than no record in the left peroneal nerve. Again, this is possibly because of his left lower limb wasting because of the prior poliomyelitis. And his electroencephalogram, around 2 hours record, had shown a diffuse theta to delta range slowing. So probably he's having an underlying encephalopathy. And since our primary consideration was an anti-VGK encephalitis, which is very strongly associated with thymoma, and also we also considered paraneoplastic encephalitis, we had got a contrast enhanced CT of the thorax and abdomen. There was no evidence of thymoma, and there was no evidence of any intra-abdominal or intrapelvic malignancies. And this is the EMG of the patient. Just a minute, sir.
Raghavendra is going to describe the EMG.
Yes, sir.
So let him describe it.
Okay, sir. Fine, sir. I just played for the others. So here we can see regular group fasciculations with high intra-burst frequency.
You let Raghavendra describe it. You let him describe it. Otherwise, he will have nothing. Yeah.
Okay, sir.
Let him describe the electrophysiology. Yeah.
Okay, sir. Okay, sir. So the MRI brain with contrast was normal. There was absolutely no neuroparenchymal abnormality. I'll just play the T2 axial T2 flare for representative purpose. So there are some non-specific white matter changes here, but otherwise, essentially, the MRI brain was normal, sir. And again, since even though we did get a positive blood mercury and urine mercury report, we still wanted to pursue the diagnosis of a possible paraneoplastic etiology, because that would completely change the therapeutic perspective. And since the patient had so much weight loss and loss of appetite, we had done a whole body FDG PET. And we can see over here, this is actually axial cuts at the level of the stomach. And this is increased uptake at the level of the pyloric antrum, as well as the lesser curvature. So we can see there is an uptake in the lesser curvature of the stomach as well as the pyloric antrum. And so we thought that maybe the patient is having a gastric malignancy, which is masquerading as a Morvan syndrome. And to our surprise, so before I go to that, this is the report from nuclear medicine. So there's a metabolically active lesion in the lesser curvature in the pyloric antrum of the stomach, as well as the distal ileum, and also a low-grade metabolically active lesion in the left lobe of the prostate gland. But however, we had done a PR exam. There was no obviously palpable prostate, and the patient's PSA levels also were within normal limits. So thinking that probably it's a gastric malignancy, we got a medical gastro opinion and a UGA scopy, but it is absolutely normal. The UGA scopy was normal. There was no ulceroproliferative lesion or even anything abnormal in the UGA scopy. So we had discussed the case with the nuclear medicine team, and actually they had mentioned that the standardized uptake value, which is usually the value that is given to quantify the uptake in FDG PET. So the SUV max in our patient is actually 2.44. But the usual SUV max, that is standardized uptake value, max value for malignancies, is expected to be 4. So putting this together with the normal UGA scopy, we came to the final conclusion that the patient does not have any gastric malignancy. But however, we are keeping the patient in close follow-up with medical gastro as well to have a low threshold for diagnosis of any future malignancies. So the final conclusion would be a Morvan syndrome secondary to mercury toxicity. So the two possibilities. So number one, the patient has mercury toxicity, which is initially presented as drug-induced Parkinson's and later triggered an autoimmune response, which has then gone into a full-blown Marvin syndrome. And the possibility of paraneoplastic Marvin syndrome would be the second possibility. But however, UGS-COPE is normal, and the final PET, whole body FDG PET was concluded to be not suggestive of gastric malignancy. So how did we manage this patient? So we had first pulsed the patients with IV steroids, and we had given injection methylprednisolone 1 gram IV OD for 5 days, followed by 1 milligram per kilogram.
But why was steroid? Why did you give IV steroids? Is it documented in literature that
Sir, we will discuss this in detail, sir.
Yes.
There is detailed perspective on this, sir.
We have
Further,
quoted
sir.
multiple case report and case series.
So there are further discussion. Yes, sir.
So we had pulsed the steroids followed by 1 milligram of kilogram of oral steroids. But however, unfortunately, on the second day of the steroids, the patient had severe steroid-related psychosis on and above his already pre-existing confusion. So actually, he had rolled down of his bed, opened the special ward door, and had literally crawled all the way till the staircase. Then we had to bring the security and ask him to bring him back. And we did get a psychiatric consultation for the same. But however, this is very transient. And after the 4th day and 5th day of IV steroids, this had improved. And for considering further immunotherapy, we had given the patient plasma exchange. But however, unfortunately, after the second cycle of plasma exchange, he had developed a sheath-related, that is central line-related sepsis, which had grown MRSA. And this is treated with IV antibiotics. But however, we did not pursue any other further immunotherapy because the patient had significant improvement in terms of his insomnia, the neuropsychiatric features, the myokymia, as well as his extrapyramidal syndrome, and was actually sent back home walking, and was actually rejoined.
One key point to highlight here is that when the sample was sent in the first few days, but the report takes long time. So report took almost 3 to 4 weeks to come back. All this management was done prior that report of mercury poisoning came. So many of the things were empirical. Yeah. Please continue.
Yes, sir. So since the patient had significant improvement and now also he's rejoined his work in the Taluk office, so we did not pursue any other further immunotherapy. The patient is under close follow-up with us and also with medical gastro for monitoring of any future gastric malignancies. So the final conclusion of the case would be Marvin syndrome, that is secondary to mercury toxicity.
Repeat mercury levels?
Sir, actually, he's only been discharged around 2 months ago, sir. We'll be getting it done next month, sir. So regarding chelation therapy, my colleague...
That's
next coming. Next discussion, detailed review is coming up. Yeah. Raghavendra's turn?
Yes, sir. So now I will pass on the thing to my colleague, Dr. Raghavendra, and he would touch upon very important points on the electrophysiology aspect as well as the diagnostic and therapeutic perspective of Marvin syndrome.
Pass on the baton. Huh?
Okay, sir.
Only one question, sir. Is there what about autonomic symptoms? All they improved? Bladder. He had started developing bladder control also, and then he started.
Yes, sir. We had removed the catheter. He had developed everything had normalized.
And BP is stabilized.
Yes, sir. Very much, sir. Stabilized, sir. But he still did have some resting tremors and cogwheel rigidity, sir. He's still on levodopa for the same. It is the only symptom that I would say it's not fully improved, sir. Others have fully improved, but his extrapyramidal syndrome has improved, but it still requires levodopa, sir.
Well presented, Pushkar. Excellent. Now we'll listen to Raghavendra.
I'm audible, sir?
Yes.
Good afternoon, everyone. I'm here to present the salient EMG findings in this case, which has led to the diagnosis, followed by discussion of the various spontaneous motor neuron discharges, following which we'll have a discussion on PNH syndromes, and in particular about the association of mercury in PNH, followed by its diagnosis and treatment. So coming to our case, as we can see here, these are continuous, undulating, querying or rippling movements of a muscle that grows across the breadth of the muscle. Thereby, we can Name this as myokymia. On further needle EMG examination, as we can see here, with the patient in the resting position, we can see these are spontaneous involuntary motor neuron discharges which are occurring in bursts with a high frequency within the burst of around 30 to 40 hertz, followed by a low intra-burst frequency. We can also see there are doublets and couplets occurring, followed by burst of myochemic discharges. These are the various myochemic discharges which are occurring with high frequency within the burst, followed by very low inter-burst frequency.
Sound is not coming, Raghavendra.
Just a minute, sir.
மாட உள்ள வித்துறாய்.
Sound is not coming. Leave it, no problem.
I can get the sound.
Okay.
Oh, the EMG.
EMG sound, sir. EMG.
Oh.
Okay, no problem. You proceed.
Audible, sir.
Now it is audible.
Is it audible, sir?
Yes, yes.
மாடு நம்ம வீடு ஃப்ரீயா இருக்கும் பாரு.
Sound is not classical of myokymia.
Some bursts are there.
Yeah.
So coming to the various spontaneous motor neuron discharges, the spontaneous discharges on EMG can be classified under three main headings, which are from the end plate zone and the muscle fibers and the motor neuron. From the end plate zone, we have the end plate noise and the end plate spike. These are the only normal spontaneous discharges within the end plate zone, and followed by spontaneous discharges from the muscle fibers. They can be from individual muscle fibers or multiple muscle fibers. From the individual muscle fibers, it involves fibrillations, positive sharp waves, and myotonia. Whereas from the multiple muscle fibers, they are complex repetitive discharges. Coming to our case, these are spontaneous discharges from the motor neuron. Starting from the spectrum of lowest frequency, they are the fasciculations, followed by myokymia, tetany, cramps, and neuromyotonic discharges, which are of the highest frequency. So any spontaneous activity is generally analyzed under these three main headings based on morphology, stability, and firing characteristics. Based on the origin of the spontaneous discharges from the end plate zone or from the muscle fibers or from the motor unit. Based on their stability, they are further classified as stable or unstable with a waxing or a waning pattern, or it can start, stop, or change abruptly. Based on the firing characteristics, based on the firing rate as well as the firing pattern, the firing rate can be either very slow, fast, or very fast. In our EMG examination of this patient, we can see these are spontaneous discharges which originated from the motor neuron, which had a fast firing rate between 30 to 40 hertz within the burst, followed by a relatively low frequency of interburst frequency, and the firing pattern was almost irregular. So this is a graph showing the spectrum of abnormal spontaneous activity. Starting with the lowest frequency are the fasciculations, followed by doublets and triplets, followed by myochemic discharges, followed by cramps and neuromyotonic discharges. So myokymia, the word in Greek refers to chyma, meaning wave. They are continuous, undulating, rippling movement of muscle, which appears to have a bag of worms under the skin. One of the important features is that the ripple grows across the breadth of the muscle. more commonly seen in the lower limb muscles, but can also be seen in the upper limbs, trunk, and the face. The other important feature of fasciculations is they are randomly occurring spontaneous single muscle twitches which lack the rhythmic quality, unlike the myokymia, and the twitching goes along the length of the muscle fibers. So, as previously described, this is the EMG finding of a myokemic discharges. They are rhythmic, grouped fasciculations, which are repetitive discharges of the same motor unit occurring with a fast firing rate within the burst. The main pathology here is due to the spontaneous depolarization of the demyelinated segment of a nerve or due to apoptotic transmission across the demyelinated segment of the nerve. So, myokemic discharges, the morphology, since they originate from the motor unit, they resemble the motor unit action potentials and they're usually very stable. However, the number of potentials may change within the burst. They may add or drop out. The firing rate within the burst is usually very high, is usually between 5 to 60 Hertz, whereas the interburst is between 1 to 5 Hertz. The firing pattern is due to the bursting of same motor units which are firing at a fast frequency, and the sound is that of a marching soldiers. However, in our case, we could not have the sound. So, coming to the cause of myokemic discharges, they can be classified as either facial or limb myokemia or generalized myokemia. Cause of facial myokemia, it includes multiple sclerosis, brainstem lesions, CP angle lesions, followed by GBS and Bell's palsy. Cause of limb myokemia includes radiation plexitis and carpal tunnel syndromes. One of the important differentiating features between radiation plexitis and neoplastic invasion are the presence of myokemic discharges, which points towards the radiation plexitis. Coming to generalized myokemia, it includes the peripheral nerve hyperexcitability syndromes, which are the ISEX and Morvans, followed by secondary to denervation like GBS, CIDP, CMT, ALS, and thyrotoxicosis. In our case, the heavy metal exposure like gold, platinum, mercury, or manganese. On the increasing frequency of discharges are the cramp potentials, which are nothing but painful involuntary contraction of a muscle that tend to occur when the muscle in the shortened position. They are high frequency discharges. They are not primarily a muscle phenomenon. They are several normal appearing motor unit potentials which are firing repetitively and irregularly. As you can see here, following a voluntary contractions, the firing of the several motor unit potentials irregularly on further magnification. As you can see, these are the same motor unit action potentials which are firing repetitively and irregularly with the frequency of around 40 to 75 Hertz. So, the cause of cramp discharges can be neurogenic or secondary to metabolic disorders. Neurogenic includes secondary to denervation like radiculopathy or motor neuron diseases. Metabolic can be due to salt depletion, pregnancy, and hypothyroidism. And our case is the peripheral nerve hyperexcitability syndromes or the cramp fasciculation syndromes. So, on the other hand, the highest frequency of discharges are the neuromyotonic discharges. They are clinically characterized by generalized stiffness, hyperhidrosis, and delayed muscle relaxation. One of the highlighting features is that the activity persists during sleep as well as during spinal and general anesthesia. They are originating from the motor unit. They resemble the motor unit action potentials, and the stability, they have decrementing amplitude, because of which they have a waning firing pattern, and the firing rate is generally very high, producing the characteristic pinging sound on an EMG. As you can see here, these are the neuromyotonic discharges, which are of very high frequency with a decrementing amplitude, producing a characteristic waning pattern. On further magnification, on decreasing the sweep speed, we can see these are individual motor units from a single motor unit which are firing repetitively. As we can see here, this is an EMG examination of neuromyotonic. Relatively high frequency of firing rate, followed by a decrementing pattern resulting in a pinging sound. So the various causes of neuromyotonic discharges includes peripheral nerve hyperexcitability syndromes like ISEX, Morvans, and VGKCs, or secondary to neurogenic disorders like SMA, hereditary neuropathy, and radiation. So summing up, the spontaneous motor neuron discharges, motor unit discharges can be from the fasciculation potentials, which are of the lowest frequency, and followed by doublets and triplets, myochemic discharges, cramp potentials, and neuromyotonic discharges. In our case, we had the myochemic discharges with high intraburst frequency firing rate of around 30 to 40 hertz, which are usually stable. And coming to peripheral nerve hyperexcitability syndromes, they are nothing but spontaneous discharges which are originating from the motor neuron, resulting in increased activity of the muscle. This was Augustin Mary Morvan, who in 1890 had described cases with increased muscle stiffness and twitching of muscles with CNS manifestations like insomnia and encephalopathy. And it was almost six decades later, it was further described by Isaacs to have peripheral nerve hyperexcitability syndromes. And coming to the epidemiology, here the points which are highlighted in yellow are pertaining to our case. So our case, it is more common in males rather than females, and the peak onset is usually between 4th or 5th decade. Our patient was a 55-year-old male, and the presence of VGKC antibody is found in most patients with Morvan's, however, can be negative, and up to 50% of the patients in Isaacs syndrome and 24% in Cramps fasciculation syndrome, of which 20% of the patients with VGKC antibody positive will have the presence of an underlying tumor, most commonly a thymoma or a small cell carcinoma of the lung. 50% of the patients will have an underlying axonal denervation without the presence of VGKC antibodies. So coming to the etiological classification of peripheral nerve hyperexcitability syndromes, they can be classified as primary, secondary, or genetic or hereditary. Primary, they are mainly immune mediated, secondary to VGKC's antibodies, which can be of the Cramps fasciculation syndrome, Isaacs, and Morvan syndrome, or they can be associated with other autoimmune disorders like myasthenia or SLE, and paraneoplastic like thymoma and small cell carcinoma of the lung. Secondary is usually due to denervation due to peripheral neuropathy like GPS, CIDP, or entrapment neuropathies, or anterior onset degeneration like ALS and SMA. Toxins like gold, alcohol, and mercury in our case. Genetic or hereditary can be due to VGKC mutations, Schwartz-Jampel syndrome, or familial episodic ataxias. So coming to the primary PNH syndromes, starting from based on the manifestations, they can be classified as Cramps fasciculations, Isaacs, and Morvan syndrome. With the Cramps fasciculation syndromes are generally associated with cramps, fasciculations, and after discharges without the presence of autonomic or CNS involvement. The presence of autonomic manifestations with evidence of myochemia or neuromyotonic discharges on EMG with hyperhidrosis favors the diagnosis of Isaacs syndrome. They're usually associated with thymoma or small cell carcinoma of the lung, and most of them are anti-Caspar-2 or LGA1 positive. The presence of central nervous system manifestations like encephalopathy, insomnia, along with autonomic manifestations like hyperhidrosis and cardiovascular instability, with the electro EMG evidence of myochemia or neuromyotonic discharges favors the diagnosis of Morvan syndrome, as in our case.
So here in the Morvans, have they written the Parkinsonism features in the previous slide?
Sir, I'm not. Just a minute, sir. I'm not hearing.
Am I audible?
You're audible.
Raghavendra?
Sir?
Am I audible?
Yes, sir.
In the previous slide, have they written the Parkinsonism? They have not written there, no? Parkinson, previous slide.
Just a minute, sir.
No,
sir.
not mentioned.
Morvan's Parkinsonism is unusual, right?
In this, they are not mentioned, but in further case reports associated with mercury, it has been mentioned, sir.
Okay, so it's a coincidence that last time we presented a case of Cramp fasciculation syndrome around 1 year back, and now this time we are presenting an other spectrum of the same illness in the form of Morvan syndrome.
This is Dr. Ramkumar from JIPMER. I would like to add one point. Actually, I think in this case, there could be two things. One, the mercury is known to directly cause Parkinsonism. Its causes mechanism might be due to loss of dopamine neurons and glutathione depletion, substantia nigra pars compacta, with glutamate increase and mitochondrial dysfunction. That might have led to the initial Parkinsonism symptoms. Then the mercury autoimmunity could have triggered the Morvan syndrome. So I think this could be thought of in our case.
No, that is what I was thinking of. Can we use? It's just a hypothesis. I don't know whether it's true or not. Whether severe Parkinsonism can be used as a differentiating feature between mercury poisoning and the primary Morvan syndrome. Can we use
No,
that
sir,
like
it is
that or
not
not?
given as such like that, sir. No,
Yeah.
one thing is mercury, as you said previously, mercury causes more of a sensory symptoms, which while the idiopathic Morvan syndrome won't have that many sensory things like mercury poisoning. That is given in literature, but this is not given. So I think I postulated that it could be the first thing could be due to the direct effect of mercury due to the mechanism I explained. Then the autoimmunity could have further kicked in and then caused Morvan syndrome. So find in that way, this call to be explained by a single thing. So that is the thing I think it is very peculiar and interesting in our case.
Fine. Proceed, Raghavendra. Proceed, Raghavendra.
Coming to the various clinical features, the most common being the muscle twitching as manifested by myokymia or fasciculations, followed by painful cramps and muscle stiffness, followed by sensory complaints, autonomic dysfunction, and CNS involvement. Muscle stiffness can present in various forms, either as pseudomyotonia or pseudotetany or pseudodystonia. The absence of percussion myotonia differentiates from the normal myotonia. On this pseudotetany, they are spontaneous or evoke the corpus spasm like posturing of both hands. However, the calcium and magnesium levels remain normal in our case. So coming to the other clinical features, muscle weakness can also occur secondary to fatigue due to continuous muscle fiber activity. So is muscle hypertrophy secondary to continuous muscle activity. The most commonly affected are the calf muscles, followed by the forearm and the hand muscles, and the degree of hypertrophy relates to the severity of muscle activity. So coming to the sensory complaints, most common are the paresthesias, dysesthesias, followed by numbness, but was not present in our case. The autonomic manifestations include hyperhidrosis, which was the most prevalent, followed by tachycardia, hypotension, urinary complaints, and constipation, which were present in our case, followed by hypersalivation and lacrimation. CNS involvement is heralded by the insomnia, followed by neuropsychiatric features like hallucination, confusion, or delusion, followed by agitation and amnesia. Some of the patients have been known to develop faciobrachial dystonic seizures or generalized tonic-clonic seizures.
These highlighted things were present in our case, right?
Yes. The ones highlighted in yellow are found in our case. So one of the other manifestations of anti-VGKC antibody syndromes are the anti-LGA1 encephalitis, which are due to CNS manifestations characterized by faciobrachial dystonic seizures with cognitive impairment, more commonly affecting the elderly males with high association of small cell carcinoma and smoking. As we can see here, this was an elderly female with right facial dystonic seizures, and this is another female with left brachiobasal dystonic seizures, which are found to have anti-LGA1 antibodies positive. So now we'll be dealing with the particular association of mercury leading on to Morvan syndrome. The effects of mercury can be classified under two main headings: the immediate effects of mercury, followed by the delayed manifestations of mercury. Following mercury inhalation, more commonly, the mercury is transported into the bloodstream and enters the CNS through the blood-brain barrier, following which it damages the neurons by various mechanisms like free radical injury and reduction of glutathione levels. The death or apoptosis of the neurons will result in the immediate effects, following which the apoptosis of the neurons will be processed by the antigen-presenting cells, and they will be further presented to the T cells, followed by the activation of B cells, which results in the production of these autoantibodies. And this latency between the acute manifestation and the development of autoantibodies can result anywhere between 4 to 8 weeks. These autoantibodies in turn will bind to these anti-VGKC antibodies like anti-Caspar-2 and anti-LGA1 antibodies, which is responsible for the delayed effects of mercury. Not only the not only the VGKC antibodies are only produced, but it also been found that following mercury exposure, other antibodies can also be produced like anti-VGCC antibody and anti-GAD65 antibody. The anti-VGKC antibody consists of mainly of two main proteins, which are the anti-Caspar-2 and the anti-LGA1. The anti-Caspar-2 are mainly located in the juxtaparanodes of the myelinated axons, whereas the anti-LGA1 are located in the hippocampus. So more anti-LGA1.
So that is what we were discussing initially, the temporal relationship between. So even if we go by the pathogenesis, it is allowed up to 6 weeks or say 2 months at the max. In our case, it was almost 6 months delay from the Siddha medicine. So the alternative source of poisoning has also to be searched. There might have been that water toxicity or some other toxicity also.
Yes.
So but as the others have shared, even they have noticed that this long gap is noticed. So even after the full detailed review, we are not able to explain that gap of 6 months in our case. And in the other cases, it was as long as 1 year or 1.5 years. So that delay is not explained by this pathogenesis actually.
Yes, sir.
So we had a lot of discussion right before this, you started your presentation regarding this latency between the exposure and the manifestation.
Yes, sir.
Many a time the detail regarding the history of intake may not be accurate. sir.
Correct. Yeah, right. That is always there. Yes. Proceed.
Okay, sir. Following the development of these antibodies, the antibodies will in turn bind with the anti-Caspar-2 or the anti-LGI1. The anti-VGKC antibodies, they are basically potassium efflux channels, which are responsible for the repolarization. The binding of this anti-VGKC antibody will block the anti-VGKC channels. Thereby, the repolarization is delayed or it is slowed down, as a result of which the resting membrane potential is lowered and it will remain close to the threshold potential, because of which the cell is getting easily depolarized and it becomes hyperexcitable. So as previously mentioned, the VGKC antibodies that are located in the axons are the nerve terminals of both CNS as well as the peripheral nervous system. The main two proteins associated with the protein channels include anti-Caspar-2 and anti-LGI1, which are the anti-contactin associated protein 2 and the anti-LGI1. The manifestations of anti-Caspar-2 involves neuromyopathy or the Marfan syndrome. The anti-LGI1 will result in limbic encephalitis. So following mercury exposure, from this paper, it has been found that it's not only these two antibodies produced, mercury can result in development of a lot of autoimmune syndromes, as well as these two antibodies. Due to the development of LGI1, result in encephalitis characterized by encephalopathy, facial-brachial dystonic seizures. And the manifestations of anti-Caspar-2 in the form of Marfan's or Isaac syndrome is as in our case, this patient was having weight loss, myokemia, encephalopathy with evidence of autonomic dysfunction. The other two antibodies, like N-type or PQ type of voltage-gated calcium channels, can result in autoimmune encephalitis, epilepsy, or even Lenz-Blake presentation, manifested by cerebellar ataxias, movement disorders, autonomic disturbances, and peripheral neuropathy. The presence of anti-GAD65 antibody can result in stiff person syndrome as well as diabetes mellitus, manifested by stiffness, rigidity, and episodic spasms, which are stimulus sensitive.
But these antibodies were negative in our case, right?
Yes, sir.
Yeah.
However, since the antibodies were negative in our case, on further researching, we have found that not only these two antibodies can result in the manifestations of neuromyotonia or the Marfan syndrome, there has been found other potassium channels like the Shaker type of potassium channels, which are one subtype of voltage-gated potassium channels, which has been found across various destinations across the peripheral nervous system as well as the central nervous system. As we can see here, this was a paper in where they have analyzed 12 patients with limbic encephalitis, Marfan's, and neuromyotonia. Here, as you can see, the first column here row represents control, and the others are patients with Marfan's, limbic encephalitis, and neuromyotonia. Here, this was the paraformaldehyde fixed teased nerve fibers from the mouse, which were labeled with the sera from the patients of control here and the affected patients here, and which they were further cross-fixed with rabbit serum against this rabbit serum, which are labeled against this antigen, voltage-gated potassium channels, which are the Shaker type of channels, and they were overlapped. As you can see here, the immunoreactivity was only at the juxtaparanodes here, but however, in patients with Marfan's and limbic encephalitis, the reactivity was found across both the juxtaparanodes, juxtamesoaxons as well, thereby indicating the possible role of Shaker type of potassium channels in the Marfan's and limbic encephalitis. However, the association of mercury with the Shaker type of potassium channels and the peripheral nerve hyperexcitability is still yet to be studied. So coming to our case, regarding the review of literature, there have been more than 20 case reports and 41 cases associated with, regarding the association of Morvens with mercury, out of which the largest one was with 32 cases published by Dr. Nanashanmugam et al. In around 2016. The mean age of these cases was between 10 to 70 years. The predominant clinical manifestations were neuropathic pain, followed by fasciculations, myokymia, autonomic manifestations, and extrapyramidal features were indeed reported in this case presentation. And
I like to add, in that case also external symptoms, there was no mild tremor, something only. Like it was not the initial symptom and predominant symptom. As you can see from this, most of the cases didn't have extrapyramidal. And even if it had, it was very mild. But in our case, it was the initial symptom and it was that like a presenting symptom. So that the reason I postulate that it might be to the direct effects of mercury, then later on followed by autoimmunity resulting in Morvens.
yes.
And pathogenesis also suggests that because it starts with the CNS manifestations, the way it has the pathogenesis has been given. Initially CNS and then peripheral. The way it spreads. Yeah.
And the main duration of exposure is anywhere between 15 days to 4 months. However, the last intake was not reported. And the main treatment was treated with, since they are found to be of immune possibility, treatment was given with corticosteroids, followed by IVIG and rituximab. Most of these patients had complete resolution of symptoms within 4 to 6 months. In our case, he was a 55-year-old male with neuropsychiatric features, insomnia, myokymia, and autonomic involvement. With the possible history of native medicine intake, however, the exact source or any other source possibility is still not known. Our patient was treated with steroids and 2 cycles of plasmapheresis and had a significant improvement after 4 months, indicating the possible role of autoimmunity, even though this patient was antibody negative. So coming to the case reports, this was one of the earlier case reports which are published from India by Dr. Pangaria et al. From Jaipur, who had described 20 clinical details of patients with neuromyotonia and association of Ayurvedic medicine with neuromyotonia. They were found to have high, strong male preponderance. However, they had a limited benefit with phenytoin, but a remarkable improvement after methylprednisolone, indicating the role of autoimmunity. This was the case report, which is showing 32 cases. The predominant manifestations in this group was the neuropathic pain. Almost all of this.
Not predominant, almost 100% patient had neuropathic pain.
Yes.
It is not about predominant. Neuropathic pain was a universal feature in this series. But
Yes.
our patient did not have pain. Yeah.
All these patients developed neuropathic pain. However, our case did not have it. But our case indeed had myokymia, fasciculations, autonomic dysfunction, followed by encephalopathy and extrapyramidal features with hyponatremia, insomnia, and weight loss. So this was another case report which was published in Journal of Neuroimmunology. Here they described 2 siblings with who had subclinical exposure to mercury for over a year, followed by the development of manifestations. And this was reported as Morven syndrome plus, since they had found the positivity of more than 2 antibodies, the usual antibodies like LGA1 and Caspar2, including anti-GAD65 and anti-PQ type of voltage-gated calcium channels. These patients were treated with chelation therapy, glucocorticoids, and IVIG, but they did not have a significant improvement even following IVIG, but they did have a complete resolution of symptoms following treatment with rituximab, indicating the possible role of mercury-induced autoimmunity. As we can see here, these are the clinical history showing the initial weeks of mercury exposure, following which one of the first manifestations they developed was the rash. And these patients, they took only local symptomatic treatment in the initial 3 to 4 weeks. The symptoms disappeared. However, they again reappeared by 8 weeks. And by the 10th week, they started developing paresthesias with hyperhidrosis of autonomic manifestations, followed by CNS manifestations like insomnia, emotional ability, and altered mental status by 13 to 14 weeks. And initially, by week 10, they were admitted in the hospital. Initially, they were treated with antihypertensives and symptomatic treatment with carbamazepine and gabapentin. And since their urine mercury levels were found to be very high, they were treated. They were started on chelation therapy with the DMSA and N-acetylcysteine. After which, though they did not have a symptomatic relief, they were started on IV methylprednisolone and IVIG, but still no major significant improvement had happened. Then they are tried on rituximab, 2 doses of 375 mg per meter square across 2 weeks apart, following which these 2 patients had a significant relief.
So somebody asked about chelation. The key point here is the first management is withdrawal of the mercury exposure. Number 2 is chelation. But in our case, what happened was the patient was started on methylprednisolone. Along with that, we sent the samples. The report came after 3 weeks. By the time the patients have already improved. So we did not give the chelation. But yes, chelation should be given. But most important point to remember is that only chelation is not enough. Immunomodulation is necessary. Sometimes as far as rituximab may be needed. IV methylprednisolone, IVIG are definite. IVMP is methylprednisolone is definitely needed. Sometimes even rituximab may be needed. Because in addition to the direct toxicity, the other etiology that mercury causes is autoimmune based. So that autoimmune base has to be additionally treated.
Yes.
Was your patient on oral steroids? Because he did not tolerate IVMP, nor did he tolerate Plex. So what was the immune modulator treatment which you gave?
No, sir, IVMP we gave for initial time when he developed steroid psychosis, but we continued despite that. We completed the 5-day course and then continued him on the oral steroids. After 2-3 days, the steroid-induced psychosis disappeared.
Oh, okay. So he had received the full quota.
Yeah, he received and he was continued even on the oral steroids. He did not need rituximab, but his
Plex also was not continued.
Plex was not continued. He developed MRSA.
Yes, that's right.
Infection of secondary. Yeah.
Just one suggestion, sir. This is well known. Maybe the VGKC antibody can be repeated. You may be second time lucky. So.
Okay. Okay, sir.
Yes, it was like in some cases they have repeated it in some different laboratories. Probably some other methods have been used, so they are able to pick it up. So it can also be tried in some other lab with maybe some other methods.
Yes.
Yeah. It's possible. Sometimes even in the same lab, sometimes it picks up second time. It's
repeating mercury levels might help regarding planning.
Yeah, we are planning. And that is therapeutically very important because if the source is something else other than the Siddha medicine, then it will be very important that what is happening
we'll
to the mercury levels.
Consider chelation also then.
Yes, we need to establish that level as normalized. Correct, otherwise, even if the source is unknown, we'll start the chelation therapy now.
Yes. Very good, sir. Thank you very much for that excellent case and very good discussion. We had extensive discussion. Professor Sundar, you can take over.
Sir. Only one question, sir. How the extrapyramidal symptoms or signs? What is the percentage of improvement after the steroids? Fully improved, half improved. He told some improvement.
Sir, I don't know. This kids will they will tell more, but I somehow for some reason the extrapyramidal features have not been prominently highlighted in the whole of the literature as far as the mercury poisoning, Morvan syndrome, or other syndromes are concerned, and leave aside their outcome.
Is he also on dopa now? Is he also getting dopa treatment?
Was there? How much improvement in your case?
In my case, I think it was not we are still giving levodopa. The Parkinson disorder, Parkinson was not much improved.
There are some improvements, sir, but still yes, and he's on levodopa. So that's the reason I was saying like whether it could be an initial direct effect of mercury, then followed by autoimmunity.
And it will become too dramatic if it turns out to be actually that patient is also having a PD.
That's what
that's what it could be. In our case, since mercury has given,
it's a primary,
very well known cause for Parkinsonism. So why can't it be the initial direct cause? As I said, the various mechanisms. Then now autoimmunity could also play the role.
Ram, what you are saying is right, but what we are discussing here is if it will be so dramatic and totally except for us that like it turns out to be additionally primary in Parkinsonism.
No, sir, IPD also like
yeah, it is very difficult.
Since mercury is a very well known cause, like most probably like we must associate like.
Yeah, and Dr. Abhilash has said that we should screen for mercury toxicity. Definitely, we are planning for family screening also, but the problem is the mercury toxicity screening is very costly. One sample costs around 5,000 rupees. So that is a costly affair, I think.
Sir, the
It's a
mercury
problem.
poisoning becomes a social problem.
Yes.
The government has taken it up in a very big way. The thermometers and BP apparatus, all those things are getting reduced. The production of in previous years, we used to get cases of mercury poisoning in children due to mercury fumes from the factories, and they were all closed. And we used to have children with pain abdomen, severe pain abdomen, with the renal tubular acidosis. What about the renal functions here in this case?
They were normal. Proteins were reduced. Serum proteins and albumin were reduced. Urine protein was not done, but serum protein, renal functions were normal. Am I right, Pushkar?
Yes, sir.
Yes.
Yes, sir. He had some hyponatremia also.
He had hyponatremia is a feature of this illness.
Yes.
Hyponatremia has been described. Yeah, hyponatremia was there, correct.
Sir, one more question. If you have found out the mercury results have come yearly and mercury is high, would you have given steroids and IVIG?
Sir?
Sorry, if the mercury results have come earlier, then would you have given steroids or only were chelated?
No, sir. Steroid has to be given. That's what he has presented, that pathogenesis, because the whole damage is autoimmune induced. So you have to remove the mercury, plus you have to treat the antibodies which are positive or negative, which have already developed.
Because in the case reports you have presented, they both have
They have
positive antibody, but your case did not have any.
No, in the previous table he has presented, they were even if they're negative, they are treated with the immunomodulation. Immunomodulation is a must.
See, Ramkumar's thesis, Ramkumar's postulation is there was a direct hit on the neurons because of mercury initially, and subsequently autoimmune induced other features. I think that was what Ramkumar was trying to say. Am I
Yes,
right,
sir,
Dr.
yes, sir.
Ramkumar?
Yes, sir. Exactly.
Yes.
That's the reason for some of the persistence of his Parkinson's symptoms also. I feel
Yes.
needing some levodopa.
Yes. Yeah.
Okay, sir. The case was very interesting, and I think we had a very good discussion, sir. And I congratulate the department and Professor Aiba, sir, for this presentation. Sir, VN, sir.
Thank you,
Yeah,
sir.
yeah.
Thank you,
It was a great presentation from both Pushkar and Raghavendra, and the entire department has to be credited, Dr. Ramkumar and of course Professor Vaibhav. We are very happy to have had this case and this extensive discussion. And thanks to all the discussants as well. As the chairperson, Professor Sundar, you took an active part in the discussion. So also Professor UMS, Vijayan, Megandan, and others who participated. Abhilesh, of course, was posing lots of questions. And so all in all, we had a very good discussion. And I thank Sun Pharma for the logistics provided. I might also add that the next forum will be from the Institute of Child Health. It will be on pediatric neurology. Institute of Child Health, Professor Lima Paulin's unit will be presenting cases. And that will be in end of July. We'll get back to you at that time.
Okay. Thank you, sir.
Thank you very much. Thank you. Thank all of you.
Thank you.
And thank you, Pioneer of Sun Pharma, for
Thank you,
putting together
sir.
everything.
Thank you so much, sir. Thanks for the
Yes, sir.
opportunity, sir. Thank you.
Yes, sir. Yes, sir. You always have the opportunity, Palni.
Thanks a lot, sir. Yes, sir. Thank you, sir.
Thank you. Thank you. Can we close?
Yes, sir.
Thank you. Thanks to all of you. Thanks, Professor Vaibhav, special
Thank you.
thanks to you. Yeah, great case.
Thank you, sir. Thank you.